They're on the table.
Good morning, everybody. Thank you all for tuning back in. We are starting day 2 of the 14th annual Neonatal and Pediatric ECLS Educational Conference. We're live from UPMC Children's Hospital of Pittsburgh. Welcome back if you were with us yesterday. If you weren't with us yesterday, thank you for tuning in and joining. We're going to go ahead and jump right into our program today. Our first speaker is Dr. Dana Furman. Dana is the co-director of continuous renal replacement therapy here at UPMC Children's Hospital of Pittsburgh, and she's going to talk to us about renal support on ECMO, which therapy to choose.
Thank you, Merritt, and thank you to the organizers for inviting me to come today. This is one of my favorite topics to talk about for sure. I don't really have any conflicts. This is just my funding, but I will say I am a termed nephrensivist. I'm dual trained in critical care and nephrology. There aren't many of us who are this interested in both things, and I'll say what got me most interested in it, I remember back to my training in residency, one of my favorite attendings drew an ECMO circuit. It was in the middle of H1N1 and drew an ECMO circuit and showed how CRT could be connected to the ECMO circuit. At that time, it was just with filters because the machines didn't allow for it. And I think it's truly when I got hooked to my career decision. So again, this is a topic I love to talk about. So what our goals for the next 20 minutes or so is I'm hoping everyone leaves familiar with the potential benefits of renal replacement therapy on ECMO, and importantly, understand considerations when choosing a mode of renal replacement therapy for patients receiving ECMO. So why do patients on ECMO need renal replacement therapy? Unfortunately, the kidney is one of the organs that gets affected with multi-organ dysfunction syndrome. It's usually affected within a day or two after the hit. Sometimes we can predict when the kidney function is going to get worse. And going on ECMO itself, so not only are these patients sick already, maybe sepsis, poor cardiac output, which is going to impact the kidney, but also ECMO initiation. You know, we've talked about increased inflammatory response, increased cytokine release, exposure to the circuit itself, contributing a hypercoagulable state or hemolysis or hemoglobinuria. So it's really not surprising that our ECMO patients have very high rates of AKI, and truly high rates. When we look at this in studies and updated this slide with more recent studies, it's certainly pretty prevalent amongst the ECMO population. In neonates with congenital diaphragmatic hernia, a population in this group, they found 71%, children with cardiac indication, 72%. And this is using, we'll say the incidence is a little varied because there's a number of definitions out there for acute kidney injury, but most of these use our most updated definition of the KDIGO definition. Adults with respiratory indications up to 78%, neonatal and pediatric patients, a larger study, 60 to 78%, and then adults with cardiac indications, 81%. So again, a very important topic. I'm glad you all are including this within the program today, because clearly this is something that we certainly all see on our patients on ECMO. We know that fluid overload is also common in patients receiving ECMO and associated with bad outcomes. This is a more recent study that Steve Gorga put out looking at fluid overload and fluid removal in patients on ECMO and pediatric patients specifically. It was a pretty big cohort for a pediatric study, 357 children treated with ECMO and CRT at 6 tertiary care hospitals, and we were included in this. And this includes a median fluid overload at CRT start, 21% or about 20%, and was significantly lower in survivors compared to non-survivors. And in ECMO survivors, after adjusting for, and people may say, patients that are more fluid overloaded are more sick, but after we adjusted for potential confounders, fluid overload at CRT start and discontinuation were independently associated with ECMO duration and mortality. So certainly fluid overload has implications for our patients, and a way that we can eliminate that or alleviate that is with the use of renal replacement therapy. Potential benefits when you think about, obviously there are ways we can address fluid overload in our patients. We have to think about what are we putting into our patients, what are the carriers and the different medications we're giving our patients, making sure we're not giving them things that they don't need to increase fluid overload, and the use of diuretics. But ECMO and CRT or RRT, you can really manage that fluid overload. You can get control of it. You can stop it from getting worse. There's a thought that maybe we can remove inflammatory mediators through the use of CRT. Really importantly, nutritional support. I always teach in nephrology that when you're thinking about eliminating or decreasing TPN or nutrition, that's actually an indication for dialysis, right? We don't want these are very nutritionally vulnerable, fragile patients. And so sometimes that's a pretty strong indication that we need to start renal replacement therapy. Obviously comes with AKI, electrolyte abnormalities, rise in BUN and the coagulopathy that could potentially happen with that, hyperkalemia, hyperphosphatemia. RRT gives us the opportunity to manage that. And then decreased use of furosemide. I mean, we do use furosemide in our unit for sure, and certainly can have some great benefits for patients. But when we're getting into extremely high doses, there's certainly side effects with that. And obviously you can't get as much precision and control when just using potentially a furosemide drip or another form of a diuretic. So, and studies have looked at comparing the use of renal replacement therapy on ECMO versus patients that were on ECMO without renal replacement therapy. This was a smaller study. It just included 26 patients in the group that received ECMO without renal replacement therapy, and 26 patients that were matched that received renal replacement therapy with ECMO. And what they found is that the use of Lasix, not surprisingly, was less in the group that received RRT. And then looking at nutrition and calories, again, the days to desired calories was significantly lower in the group that received renal replacement therapy. So in our children receiving ECMO, as we know, nutrition is really, really important for these patients in terms of health and getting better. So a case presentation to frame, because really the charge with this talk is talking about which modality to choose when we think about renal replacement therapy for our patients. A 14-year-old male with a history of a URI for 4 to 5 days comes into the PICU with hypoxic respiratory failure, is found to have a necrotizing pneumonia, sepsis, is intubated, and then ultimately cannulated for VA ECMO. And weight coming in, or actual weight that we try hard to get a dry weight on these patients, and it's estimated for this patient to be about 61.2. And then unfortunately, we notice after getting on ECMO, his urine output is dropping, his creatinine is rising. We see this quite commonly, and the edema on exam is getting worse for this patient. And the team decides this patient needs renal replacement therapy. There's a number of questions and considerations when you make that decision. What form of renal replacement therapy to choose? And we'll talk about those options. What are the modes when you think about if you choose CRT or continuous renal replacement therapy? There are different considerations in that prescription. And then what are the methods used for providing once we decide we're going to put a patient on a circuit? What does that mean in terms of connecting the patient on ECMO? So one form of renal replacement therapy that I know everyone's heard of is peritoneal dialysis. And I'll say certainly not necessarily an attractive option in a patient who's never been on peritoneal dialysis going on to ECMO, but we may have patients that are already on peritoneal dialysis due to chronic renal failure, and maybe a consideration in this patient if a PD catheter is already in place. It's a form of dialysis to be familiar with, and that we quite simply instill a fluid, a dialysis fluid, into the peritoneum. It dwells for a certain amount of time. Dialysis is achieved through the patient's actual peritoneal membrane, and then that fluid is drained. And you can achieve fluid removal and improved electrolytes with this mode of therapy. Certainly not as much control as you would with something like an intermittent hemodialysis machine, or much more commonly, what we would think about in our ECMO patients is the use of a hemofilter or an actual inline circuit with our using CRT. And certainly these latter two options are what we use traditionally in our ECMO patients. These patients are, as I don't have to tell this group, hemodynamically unstable. And so tolerating big fluid shifts with something like intermittent dialysis would be pretty undesirable. So what are the modality options? So as I said, continuous renal replacement therapy means just that, it's continuous. It can be done over 8 hours, it can be done over 24 hours, but it's done over a slower period of time compared to intermittent dialysis. And a common way that we achieve this is what's called SCUF. We'll use the term slow continuous ultrafiltration. So this is quite simply removing fluid from the bloodstream via ultrafiltration. In this form of therapy, we don't use any form of dialytic fluid, meaning we don't use replacement fluid, we don't use countercurrent dialysis, and we're simply using a filter. That filter could be in a machine or just in line with the circuit, and we'll talk more about that when we do SCUF. But alternatively, you may have a patient that needs some clearance. So the BUN's rising, or the electrolytes are abnormal, or we want to clear some lactate. And so we talk about another alternative way of performing CRT called continuous veno-venous hemofiltration, or CVVH. The idea behind this is that it's providing what we call convective clearance. So what's happening is through pressure, and as shown in this picture, the patient's blood is going across the circuit, and through pressure and what we call almost like a solute drag, these electrolytes that you want to remove, usually urea, phosphate, potassium, are going to come out in the hemofiltrate. And this is again through this process of convective clearance. It's effective for the removal of larger molecules, urea, creatinine, phosphorus. Obviously, you'll hear us, we talk a lot on rounds. We worry that other things that we don't want to clear are coming out, like antibiotics or drugs that are important for the patient. But this is a form of therapy that you may just run. Again, we'll talk about a replacement fluid that we use for this. Alternatively, we could do CVVHD, continuous veno-venous hemodialysis. And this is a form of diffusive clearance, where what's happening is you're running the patient's blood is running through the filter, and then you have a dialysis fluid that we order and runs countercurrent or opposite to the patient's blood. And what's happening is things are going to go from greater concentration to lesser concentration. So those solutes or electrolytes, such as phosphorus or creatinine or urea, are going to move from that area of greater to lesser concentration and come out in the dialysate. And so this is another way of removing those substances that we want to remove, and that solute moves down its concentration gradient. It removes smaller molecules when compared to CVVH. And so it's really good. Urea is a relatively small molecule, and so it's pretty effective at clearing urea. So you'll see when we do intermittent hemodialysis, we'll look at a urea reduction ratio and how effectively we're doing that. This requires a dialysate fluid. And most commonly what we do when we want to get clearance is we'll order CVVHDF, or the combination of these two forms of therapy. So both convective and dialytic clearance, and it's termed continuous veno-venous hemodiafiltration, both diffusive and dialytic clearance. So depending on how much clearance you need, we adjust our prescription accordingly. And so again, there's nuances to these patients. Some patients may simply need fluid removal, where we talk about SCUF. Some patients need a lot of solute clearance, and we may move to something like CVVHDF. So, we've decided, say we want to achieve fluid removal and we really just want SCUF on a patient, or alternatively, we want more clearance. The next question is, how are we going to achieve this using dialysis? And the methods to perform CRT on ECMO are actually quite simple. There's three options when you think about it overall. You can use an inline hemofilter, which we certainly have used, where you literally just put the hemofilter in line with the ECMO circuit, and we'll talk about how that could look. There's no pressure monitoring with this option, which we'll talk about how that could be less attractive in some cases. You may take an actual machine and put it in line with the ECMO circuit. And really, the nice thing about both the inline hemofilter and the inline CRT device is it allows the need for not additional access. And as we know in these patients, especially in our pediatric population, additional access is not our friend. There's a lot of challenges with that, and most of the time that's not an option. But independent access might be an option, I think more in the adult world, where you run CRT completely separate from the ECMO circuit. And that can be an option as well. So when you decide you want to run renal replacement therapy in line, as I mentioned, the hemofilter is an option. And this is a nice review, although it's getting older, from 2012 from David Askenazi, if anyone's interested. I think it still serves as a nice review in terms of how this could be set up and considerations within this. So basically putting the hemofilter, we always, as we talk about, want to keep either the device, if we're using a CRT device, or a hemofilter pre-oxygenator, where the oxygenator works as a method to collect air and clot formation. And so the hemofilter is generally placed post-pump pre-oxygenator, and blood travels into the hemofilter and then pre-pump as it leaves the hemofilter. In this example, they're showing an example of using dialysate fluid running countercurrent through the filter itself. And when you think about this, the way that ultrafiltration is occurring is it's through pressure. And that pressure, when you're using a hemofilter, is not regulated as it is with the machine itself. So there can certainly be, and it's been studied, inaccuracies with the amount of fluid that we pull off this way. So generally this ultrafiltrate is removed. It's removed via pressure, that transmembrane pressure across the filter itself, and the use of an IV pump. You could use replacement fluid. So again, this is providing that convective clearance. This is providing dialytic clearance. And so in this example, this would be CVVHDF with the use of a filter inline as one option. But alternatively, using a machine itself, so you actually take the dialysis machine, and we'll talk in a second, we have new dialysis machines here at Children's, using the machine in line with the circuit. And with a centrifugal pump, or as we use here in ECMO, the idea is you place the machine post-pump and pre-oxygenator, and that blood is removed, again, post-pump and goes through a CRT device and then is returned to the circuit after undergoing dialysis, whether you order CBVH, CBVHDF, or you could even do SCUF with this method, and is returned to the patient pre-oxygenator. And certainly the question is, which method is best? Again, this is a nice figure that actually Merritt shared with me, and has been used in a couple of editorials about this. We're again showing this idea where if you use a hemofilter, putting it post-pump, pre-oxygenator, and going back to the patient pre-pump, and then the idea of a circuit in line where you're using it, where you're actually achieving effective clearance this way. So the answer is there's no clear recommendation on which connection between ECMO and CRT should be used in the literature to get the optimal approach. However, importantly, when you think about using an inline hemofilter, it's not designed for use with high pressure systems. The maximum volume is limited to 1 liter per hour, and the amount of fluid removed is absolutely less accurate and prone to error. And people have studied this, and studies in adults have shown up to 800 milliliters a day of inaccuracy when you're using the filter in line. There's no pressure monitoring, unlike the use of a CRT device, and you can get delayed detection of hemolysis, which we of course do monitor for in all of our patients on ECMO, but you worry filter rupture, clot formation with the use of an inline hemofilter. So we've discussed limiting the use of the inline hemofilter to patients when we're doing SCUF, when we're just pulling fluid off. But when you're thinking about adding in replacement fluid, dialysis fluid for clearance, in that way, using the actual CRT machine device as a more attractive option for these reasons. And our smaller patients in particular, you really worry these fluid shifts could be quite massive. And I think we've all experienced times where we're worried about that and requires extremely close monitoring. There's always going to be nuances to different patients and what things might be desirable, but this has been our approach from that standpoint in terms of where to choose. Again, there's not a lot in the literature in terms of this, and this would be something that could be certainly, I think, studied and important to study. This is a study Dave Saluski did years ago, but I think still is one of the bigger studies in this space in kids, looking at a retrospective chart review of patients on CRT on ECMO. And they characterized, really his goal was to look at fluid overload and fluid removal on mortality. But I present this here because I think the results of his study and some other case reports favor the use of the dialysis machine. His overall survival, again, this was 2012, was 34% in his cohort. And the median survival, fluid overload at CRT was lower in survivors compared to non-survivors, which has been shown in almost all studies, or in all studies related to this. But I thought important, survival was lower in the patients that received CRT with the hemofilter placed in line and compared to those that received the CRT with the PrismaFlex. Now, granted, there could be, the severity of illness was similar between the groups, but one might argue were the kids sicker in some ways who receive the hemofilter in line. Absolutely could be possible. We may go there if someone's more unstable potentially. So there could be obviously confounders in this, but just something to consider when we're thinking about which way we want to perform CRT. This was another study out of Seattle that looked at patients undergoing CRT while on ECMO. It was, again, a small cohort, 42 patients, and after adjusting for factors such as time, an integrated CRT was associated with significantly lower, and this is the machine, compared to the free flow or using just an inline hemofilter. So less error they showed, and then duration of CRT was shorter, and one might speculate, was this due to better, more tighter control of fluid using the device itself as opposed to the filter. So it makes you think. I will say we are planning to, we're part of a very large cohort of CRT patients across the world. Now we have 7 countries and multiple, I think we were up to about 2,000 data points. We're going to study this in a bigger population. But to move towards the end here, I just want to introduce you to the Prismax. This is our new machine. It's an upgraded version of the PrismaFlex. You'll see it, it works. It has the same capabilities to be in line with ECMO, to simplify therapy and more efficient treatment, improve accuracy. So you'll see this coming into the rooms. And really a thank you to all of you. We have, this is a picture including the ECMO team, the CRT team, and the plasmapheresis team when we were coming up with our trifecta of treatments for these patients. And we've come up with such a beautiful protocol for this that has gone great. Really proud to be part of this team here. So thank you all, and I welcome any comments offline. Always happy to talk about this topic. So, thank you.
Thank you, Dana. That was a really great talk. The next talk we have lined up for today is going to be presented by Dr. Kelly Austin. Dr. Austin is one of the general surgeons here at Children's that is on the ECMO cannulating team. Dr. Austin is the director of the Surgical Critical Care Residency Program, the director of Pediatric Colorectal Surgery, and the surgical director of the Pediatric ICU here at UPMC Children's Hospital of Pittsburgh. Dr. Austin is going to talk to us about, is ECMO on the menu? Ordering ECMO for high-risk procedures.
How do I move this? So you click the mouse. If you want to pull it, just move it. It'll proceed. You click anywhere and it'll advance.
Right, good morning. Thank you for having me. And I hope this is somewhat enjoyable. We'll see. Basically, I just wanted to give a couple goals initially, and there will be some slides I'm going to kind of buzz through quickly because they're a little bit of a review, but at the very beginning. So I would like to hopefully make a point about understanding when you can preemptively plan ECMO for elective procedures as much as possible. So, I mean, in a situation of high risk surgical procedures that might benefit from perhaps preemptive ECMO. So this is more of a planning strategy because I'm trying to avoid a critical crisis. And so we'll talk about those. And then I'd like to hopefully convey information regarding a stepwise decision process that you kind of go through to see if these certain operations might be worthwhile to consider that. And there's a lot of technological advances that have made ECMO safer. And actually, it's surprising that we don't use it more frequently, actually. And then also to learn how to maybe optimize that surgical patient who's on ECMO. So, I mean, this is historically, you know, we use this obviously for the indications for patients who have respiratory or cardiopulmonary failure that are deemed reversible. But in past, we've also used it mostly for patients who just needed salvage. That's last ditch effort. And there are, of course, some general indications which you're very familiar with, such as the inability to oxygenate or inability to ventilate despite maximum medical management, and patients who are persistently in persistent shock, or maybe we have considered bridges to treatment, such as bridges to transplant and things like that. That's been relatively used frequently. But there are some relative contraindications, and these are relative, and I made this bold relative because it's becoming less clear and maybe a little bit murky when we start to realize how good we are at support nowadays. And I don't want us to miss the mark. I think we should try to really make sure we're really looking at this closely. But obviously some are more relative than others, but someone such as an active trauma patient, nowadays it's not such an unheard of thing as to potentially use ECMO in a patient who's has significant bleeding or trauma, and because that might be the only way to cure them or to fix their injuries. Someone who has lethal congenital anomalies or significant poor function, that's another thing that will obviously be a contraindication. But today, I really want to spend the time on procedural ECMO and say that it's not so uncommon to consider the use of ECMO in advanced general, mostly thoracic, but some general surgical procedures as well, outside of the cardiac or the transplant setting. And, the use of ECMO can also help our perioperative kind of and postoperative management for the patient. And then typically in some of these operations have been in the past supported with cardiopulmonary bypass. And there's some definitely theoretical advantages over ECMO from central cardiac bypass or cardiopulmonary bypass. Obviously, it's much more miniaturized, circuit. It has smaller priming volumes. There's no cardiotomy that has to be going on. You can perform it obviously, and then have the patient use it for weeks to days after therapy or after surgery. They can be awake and ambulate nowadays and have less anticoagulation, less bleeding, et cetera. So I really want to talk about procedural ECMO that is a bridge to facilitate high-risk surgery and help with procedures and perioperative stability. And these in the past, might have been procedures that weren't even undertaken because the risk of surgery was so high. And also, it can actually help you make a decision on the outcome of the patient if you need to buy some time, or to help wait till you can get either an organ for transplantation or a device that can help stabilize it. So there's three main surgical procedures on ECMO. This is where I want to focus our attention really, and the controlled, planned, supportive surgical adjunct. And we have to have a very good safety net and plan. And believe it or not, I've done a lot of whitewater rafting. My husband's a geologist, and we go down the Colorado River frequently. And some of these waves become up to 20 feet high. And I can promise you that this group looks very, very good. They're like all assuming a good position. They've got their life jackets on, they're prepared, and they've probably scoped this river, this particular thing out. The raftsman's really very clear on this. But, and we all know that there's problems heading downstream. This is what happens to us in surgery. In a very high risk procedure, you're like, this is going to be awful. And what can we do to make this better? And sometimes you don't have a plan, or you didn't expect something to happen. And there's something where you're reactive and you're really rolling with the punches. And we've all been out of control. And that's what a lot of times it feels like with ECMO. And lastly, this is what we want to avoid, the crisis. That's the most critical last ditch effort, that you're like, it's a Hail Mary. You have nothing else to do but to try to save this. But this is where we're focused. And, I can guarantee that this group has also scoped out this rapid. There's a group down below here. They've already been down it. They probably watched how that group did it. They probably know all about these rocks, and they're prepared for this, this rapid. And some of the places that we could do this and prepare most for this, and it's probably most useful, is something like airway surgery. And airway surgery makes sense, but there's certain different types of airway obstruction that might require ECMO. Some airway obstructions don't, such as those proximal airway obstructions. You might be able to slip past them with a fiber optic. This is a child that had a little cone obstruction, like plastic thing up in their upper larynx. And so this particular patient, maybe a tracheostomy tube would have been enough, or just a good fiber optic intubation to get past it, to give you an opportunity or time. But, the more difficult, severe obstruction below the larynx, where, even with a patient that's actually having their own spontaneous respirations might be okay, but the second they undergo some kind of neuromuscular blockade, then they lose their own generation of pressure. It might be a real issue. And it also depends on left or right, because that can make a big difference. Dislodged stents or foreign body removal can be something that we'll go after, that we might consider VV ECMO preoperatively, or even relief of external compression. When we have a patient who's a common scenario is a child with lymphoma that has an anterior mediastinal mass that's going to have a significant compression, where in the past this might have been a cardiopulmonary bypass patient, but at this point it's something that we might be able to help with VV ECMO while we can initiate therapy for lymphoma. So the other things are very this might make sense as complex tracheobronchial procedures, especially those involving by both bronchi or a central tracheal problem. These are often life-threatening without some control of ventilation and oxygenation. But we often, believe it or not, we even see some patients who have complex tracheobronchial injuries from trauma. And if you have the time, obviously, you might be able to initiate ECMO. And in this situation is a case, it's a report of a patient that had successful reconstruction of a complex bilateral bronchial injury under ECMO support. And they actually got the ECMO done in the ED and then went straight to the OR for reconstruction and then ultimately to the ICU. And this obviously gave them time to fix a very aggressive, serious problem. Again, I touched on briefly oncologic cases such as the mediastinal masses, but also there's big abdominal masses such as pheochromocytomas and neuroblastomas and things like that often involve the abdominal aorta, or in case the inferior vena cava, that can become difficult. In children, it's not as common that I'm dealing with stent dislodgements, but I have had a personal patient at a button battery ingestion and I'm going to present her pictures here in a second, regarding that caused ultimately a 1.5 centimeter injury into the left main stem bronchus, about 5 millimeters below the carina. And at the same time, a 2 centimeter injury to the esophagus, because she swallowed the button battery that stayed there for days and it eroded into the left main stem bronchus. And so this is obviously concerning because you're going to have a patient who's intubated and relying, to do that repair, relying on just single lung ventilation on the right. And the patient's going to be in the right lateral decubitus position and having her left chest up in the air and not using that left lung, but all the lung that she's going to be breathing on is going to be like on her side that she's dependent upon. And also you're not going to have access to her right IJ at the time of doing that procedure, potentially. But we actually did choose the right chest for that approach, and I can explain it later, but it was mostly because of the arch and whatnot, and was able to do that, but she went on VV ECMO and that was very helpful. Also, patients who have pneumonectomies, and we have children that have had necrotizing pneumonias, and I will present one of those patients as well, that had to have a pneumonectomy, and this was obviously complicated. But they did very well by helping us with placing a patient on VV ECMO. So when you go to, it's nice to have sort of a stepwise approach to this, and one of the ways to think about it initially is, first of all, is this a patient that has congenital cardiopathy? Like, is this, a patient that has a known cardiac problem? This is more for the neonates or the younger patients, but if they do have that problem, then and they need some kind of airway issue, then this might be a consideration to do, a median sternotomy and consider a combined approach. And that would change the way you would approach this. You might consider cardiopulmonary bypass as opposed to, or central ECMO as opposed to peripheral ECMO. But, you know, if you have a patient that it doesn't have any of that and just needs lung surgery, and they have really poor starting respiratory status, and you're going to subject them to all the inflammation of the stress of the surgery and the postoperative edema, and they also have associated morbidity from their lungs to begin with. They've been sick for some time, such as my patient with the necrotizing pneumonia. Or if they have bad pulmonary hypertension, this is a patient that you should consider preoperative cannulation preemptively. Obviously, it's a super high risk operation. The parents have to, you know, have a good discussion. And it's also something to think about is like, what's your exit strategy off of ECMO? How long are you going to try this? You should have this discussion ahead of time. But if you have to consider whether you have an opportunity for selective intubation, or if you have a chance to do cross-field ventilation. And again, if any of these are, depending on the type and the location of the lesion and where exactly they are, that should factor into your decision for ECMO. So in the process of doing this, you've thought about it preoperatively, now you're in the OR and you still aren't 100% sure you want to use it, but you want it to be available and you're kind of having it close by. If anytime you have a patient, you know, that you put into position and they've deteriorated, if there's some form of blood gas that doesn't look good, and whether they're, you know, now that you've given them spontaneous, or you've taken away their loss of spontaneous ventilation, then you should, before you make a decision, you can still consider putting some, a real surgical incision for your procedure. You should consider an ECMO surgical procedure, because once you get down that path and you get out of number one, for my my kind of rafting analogy, it's so much harder to fix. Okay, so you always want to have a rescue strategy and always anticipate. So it's sometimes we just have ECMO on standby and we have them outside the room with the pump and we're prepared and we have everything set up to go if we need it. But that's actually, you know, that actually takes into account, again, your access to the neck, access to the groins, access to the patient, and you know, if you're how best to do it to be the safest. Planned ECMO is always better than crashing onto ECMO, and I'll get into some of the stats about that. But the cannulation sites also are very important to consider. And if you're not going to have access to the neck, and when you are in a certain position doing left lateral thoracotomy for a pneumonectomy, you should think about that before you go to that next step. And again, it's nice to anticipate the timing of weaning. While you're on ECMO in a big lung case, there's been some recommendations that you could how you should optimize the ECMO flow. It's reasonable to kind of have the flow maximum when you're, and really minimize flow, really minimize the lungs at that time of surgery. And, you know, there have been people who've used this for really bad Fole disease and bad emphysema, and also people who have serious empyemas and they need decortication. And it is actually easier to do the decortication with a ventilated lung, perhaps. But I don't have a lot of experience with that on those. We really avoid that so frequently here. This is my little girl with a 2-year-old that had the button battery. And I'm just going to bring this up to your attention because I think she got a little delayed. Everybody thought this was a coin. But if you look close on lateral, you can see that they see the 2 rings, the little hollow kind of halos. That's signs of the button battery. And button batteries that are stuck in the esophagus are extremely dangerous. And Barb Gaines actually took a button battery and put it in a hot dog overnight, and it bore a hole through the hot dog because it's a current that goes across the salt that's in our tissues that just smokes the sperm. So this patient is the one that had that left bronchial, mainstem bronchial and esophageal injury, and we ultimately did a BB ECMO through her right neck, proceeded with repairing the bronchus, and then disconnected her esophagus, left her in discontinuity for a while, and then came back to fix that at a later date. Ultimately, she healed up very nicely, and I feel, well, am I going in the right direction? How do I, what am I doing wrong? Okay, all right, so again, I'm just reiterating a difficult or impossible one-lung ventilation when you have some patients with limited pulmonary reserve. And in the adult world, you'll see more of a patient who's had a cancer, maybe had a pneumonectomy, and now they have the contralateral side, needs a wedge resection for a questionable lesion. This is a classic story that might be difficult, or esophageal cancers that erode into the mediastinum or into the that. So sometimes this is very difficult to make a decision, and there aren't any real guidelines. If everybody wants, like, give me some just numbers, but there are predictors of hypoxia, and you can look at just how bad the arterial PaO2 is on their preoperative 2-lung ventilation. If it's pretty bad, you're going to have trouble, obviously, with 1-lung ventilation. And again, you have to remember that they're going to be compromised. The one lung is going to be compromised by edema, by maybe a persistent air leak, possibly by infection. So that has to be taken into account. This was a 21-year-old cerebral palsy patient that had a severe necrotizing pneumonia on the left, and so bad that he had actually had multiple bronchial bleeds and hemoptysis, and had to have IR coil his vessel. And it was to the point where everyone felt that he was going to die from this into his, like, by a massive bleed if we didn't do something. So I did kind of have a very long discussion with the family, and ultimately we felt that, well, this, I felt sort of that this was a Hail Mary, but on the other hand, it's as controlled as it could possibly be. And we placed, we placed the an Avalon VV cannula and kept it running. Initially, my hope was just to sort of somehow have it there, but not using it, but it's impossible to not let it clot, so to not have some kind of circuit going through it. So then he went into the right lateral decubitus position. We did the operation, which was extremely bloody, very difficult. And at that point, I didn't feel comfortable closing his chest. And so we packed him with 15 lap pads and a wound vac. And he got decannulated the very next day. He did great postoperatively. And on post-op day 2, he went back to a washout of his chest and got that removed, and his packs removed and his chest closed. And he surprisingly did extremely well. And it was huge relief not to lose this patient on the operating room table, obviously, or to, and to have that success. And I feel very happy about that whole process, that it really helped. There are also patients who need help with their tumors, and not just from the fact that it's necessarily centrally located and around the blood vessels, but something like a pheochromocytoma can have life-threatening cardiovascular problems, such as the massive release of the epinephrine or epinephrine, things that are going to cause circulatory arrest potentially. And so you can actually prophylactically control their support with we try beta blockade and alpha blockade and all this, but you can still potentially control them with ECMO as well. And there are other patients that might have a left chest mass, such as a descending aorta mass, that in this situation they had to replace the descending aorta on the left. And I did not do this, but the operator used ECMO to get the patient through that. And again, the mediastinal masses are something that it's very important to consider. If a patient preoperatively has postural symptoms, if they can't breathe when they lay flat, they have greater than 50% tracheal compression. Normally what happens is, if we can get to a little piece of tissue while they're sitting up to make a diagnosis, and our hematology oncologist can start therapy, they don't have to truly have a resection with this. But if it's something that, and because usually they'll respond very quickly to medications, and that will just kind of melt away over a very short time. And they don't absolutely have to go through this route. But if you happen to be in this scenario unexpectedly, then you're going to find yourself being happy. Now, the problem with this is, if it's a solid mass and it's, you might not want to try the right neck, right? I mean, that might be a problem because you could perforate something. So it might be a better approach to go through the groins and get someone started on ECMO through that exposure. Femoral cannulations, and then this is a complex mass involving the IVC where ECMO is used to assist. So what I'm going to finalize up here in a few seconds, but I wanted to explain that, we're really trying to avoid the run with the punches and the unplanned kind of unplanned event. But there are times that's necessary. And this does increase the risk for iatrogenic trauma, hypoxemia, and cardiovascular collapse. And it's not something we want to be at. But there are times you sometimes feel like it's more like this rapid that you're going to go down. And, it's not a good feeling. But there are times where in our ORs, you might see this, an intraoperative need for ECMO, and especially if they have some type of anaphylactic shock in response to a medication. In that situation, the vessels dilate so significantly, they get a very bad hypovolemic problem, and they have edema, decreased blood pressure, decreased organ perfusion, and distributive shock can result in someone needing emergent ECMO. And they could have PEA arrest or VFib. They could have systemic toxicity from a local anesthetic injected into a systemic circulation. I've seen this happen in a perianal situation where someone injected some epinephrine or lidocaine into a bloodstream and the patient had an arrest. There's also malignant hyperthermia, and cardiac arrest associated with anesthesia happens infrequently, but the mortality rate is extremely high. So if you have to be and do ECPR for witnessed cardiac arrest, this might occur, say, in massive pulmonary embolism, cardiomyopathies, pheochromocytosis crisis that we talked about briefly, and pulmonary fat emboli. I've seen patients with just air emboli from even laparoscopic procedures that have somehow injured the umbilical vein, or they still had a patent umbilical vein. So when you get in a situation, increased CPR duration and increased lactate levels and decreased pH are associated with the highest mortality. But after you get a CPR initiated, the other things that are obviously associated with badness is a pulmonary hemorrhage or neurologic complications, and these things are most predictive for poor outcomes. So, but we can right this ship by being as prepared as possible to avoid that. Those are unavoidable things, but it might be necessary to proceed on ECMO and in the operating room. And we really want calm waters. That's where we'd like to be. So I appreciate your time, and thank you.
Kelly, we have one question that came in the chat. And the question is, will you ever do an intermediate to this and make a patient ECMO ready by placing catheters in the vein and artery that you can quickly use to wire in and dilate to insert cannulas quickly if and when you need it?
Oh yeah, that's a great question. And actually some of these patients did have a central venous line, and a lot of these kids, they did get central venous catheters when we took the cannulas out. But I think that's a wonderful question, and I think for especially those patients with that one patient that had the mediastinal mass, I think if you had the lines in the groin ahead of time, that would have really facilitated access to that patient very easily. The older the patient, the better, for that, for sure.
One other question that quickly came in that might be better for tomorrow's ECPR panel, but I'm going to put it out there now in case the listener can't tune in tomorrow, is what's the time limit to initiate ECPR following cardiac arrest?
Oh man, that's so subjective. I don't know if we have a hospital policy. I feel like a witnessed arrest, I think our team is going to do everything we can here in the hospital to put that patient on. That has to be an individual decision, but I don't think we have one per se. I imagine each surgeon you could ask would have a different number, and each case would be a little bit different. And it would kind of depend on, did we think we had some perfusion when we're doing it? Are we getting good compressions? Do we feel like we're making good progress on that? Is it somebody who, hasn't shown any signs of life at all, and we've been working at it for some time and we haven't, I think if they're here in the hospital and we can, in the operating room especially, I feel like it would be unlikely to have a time limit in that. But somebody who's come in from the field is a whole different story, and that's a lot difficult, more difficult. So, I don't think I answered the question really, but well, yeah, I'd like our panel to know. I personally haven't made a number. I think it's an individual play-by-play situation. Thank you.
So continuing on with our surgery on ECMO session here, we're going to bring Dr. Paul Waltz up. Dr. Waltz is the Associate Clinical Director of the Division of Pediatric Surgery, the Associate Program Director of Pediatric Surgery Fellowship, and the Surgical Director of the NICU. Dr. Waltz is also another one of the general surgeons that will cannulate for ECMO here at UPMC Children's Hospital of Pittsburgh, and he's going to talk to us about general surgery on ECMO.
Hey, good morning. This will dovetail a little bit with what Dr. Austin just touched base on. So we'll start with a case. This was actually a case within the past year here. This was a 39-week infant. Really no prenatal concerns. At 1 hour of life was noted to have a poor color and respiratory distress, was rapidly transferred to the NICU, intubated, care was escalated, high vent settings, nitric started, and rapidly progressed to a transfer call for ECMO. AVG before transfer, pH was 6.6. I don't think I've ever seen one that low. Upon arrival here, almost immediately cannulated onto VA ECMO through the right neck. One of my favorite clinical phrases, the baby was stable on ECMO while we were trying to figure out, what had happened. And then on ECMO day 4, walking into the hospital Saturday morning, reviewing the films, checking cannula position. Just a point as to why you have to look at everything on the film. On the supine film, you see some hyperlucency over the right upper quadrant here, suspicious for free air. We got a cross-table lateral, which confirms that finding, really large volume free air. So now you have a patient on ECMO that still needs to be on ECMO, and now you have concern for hollow viscous perforation in the abdomen. So you're about to hop on one of those whitewater rafting trips that Dr. Austin just described, hopefully one through the smooth waters. So briefly, I'll just talk about experience of general surgery procedures on ECMO from some reports that have been published, and then we'll talk about managing anticoagulation for these procedures. Obviously, the experience, this is a heterogeneous population. It's going to vary by center. This is really a case-by-case consideration. It's hard to make too many generalizations. And then for managing anticoagulation for someone that's on an ECMO and then has to undergo a bigger surgical procedure, what I have typically in the past extrapolated is really the experience of CDH repair on ECMO. There are some centers in some cases where you will repair congenital diaphragmatic hernia on ECMO. And there's a reasonable body of literature on strategies on how to manage the anticoagulation around those procedures. And so for me, I tend to extrapolate that to a laparotomy on ECMO or another surgical procedure on ECMO. So to start, this is one of the bigger reviews of surgical procedures in neonatal and pediatric patients on ECMO. This is from the Netherlands. It's a 10-year review. They looked at 221 patients that required ECMO support. They did specifically exclude cardiac and CDH repair. And then just to comment, we'll talk a little bit more about this later in the talk, but their perioperative anticoagulation protocol for this center, they ideally had platelets greater than 150, fibrinogen greater than 1 gram per liter. They used TXA, which we'll talk about later. And up till 2015, they reduced their heparin to targets of APTT of 50 to 75. And then after 2015, they would just hold the heparin for procedures. So what they found of those 221 patients, 32 or 14% required some procedure on ECMO. And that bar graph there shows the breakdown. About 30% were thoracotomies, 20% laparotomies, 15% fasciotomies. They did count surgically revising ECMO cannulas as a procedure. And then to a lesser extent, chest tube placement, thrombectomy, tracheal reconstruction, cut down A-lines, tracheostomy. Of those 32 patients that required a procedure on ECMO, about half required multiple procedures. Almost all had some form of a complication, as you'd anticipate, usually a bleeding complication. And the mortality in this subgroup was about 50%. Most of these interventions were for therapeutic purposes. Some were for diagnostic, as they defined them. Looking down the breakdown, for thoracotomy, 6 of the 17 thoracotomies were for lung biopsy, 3 for pneumonias, 3 for trying to tease out the underlying etiology of pulmonary hypertension. 5 of those patients died, but not as a direct result of the procedure. 5 of those thoracotomies were for intrathoracic bleeding, and 4 were for effusion or empyema. And then of the laparotomies, half were for suspicion of abdominal compartment syndrome. Again, the overall surgical mortality was 50%. A quarter of those were after cessation of ECMO support for futility. But the mortality was not significantly different from their cohort that did not require surgical intervention. So, the need to pursue a therapeutic or diagnostic surgical procedure while on ECMO shouldn't be an absolute contraindication, and there should be ways to try to strategize to set yourself up for success. This is a recent paper from Riley Children's Hospital, a little bit different of a population. They looked at 6 open abdomen patients that then went on to ECMO support, so patients that had a laparotomy or a major abdominal procedure and then relatively quickly required ECMO support postoperatively. What I like about this paper was that their anticoagulation management was relatively straightforward. They really just utilized a high-risk heparin protocol with lower targets for their anti-10A, 0.3 to 0.5. And what they found, again, it's a small cohort, limited numbers, but they did match this to propensity-matched closed abdomen cohort of ECMO patients. And what they found was that there was no overall difference in bleeding complications or blood product utilization in this post-operative laparotomy population, and 2/3 survived to discharge. So just showing the breakdown for bleeding complications, the light gray bars are the open abdomen patients, the darker are for the case or the cohort. No difference in cannulocyte bleeding, CNS bleeds, chest bleeding, abdominal bleeding. Likewise, while there's a big range here, no significant difference in blood products or component products for the cohort. And then finally, just to look at chest tubes specifically, even minor procedures are not without potential complication while on ECMO. This is pediatric patients on ECMO that required chest tube placement at a single center. They found 27 patients who required chest tubes, and 6 of those ended up with major bleeding. The table shows the details of those. The first 2 had bleeding at the surgical site. Both of those survived. One ended up with a massive hemothorax that ultimately died after withdrawal of ECMO. 2 ended up with pulmonary lacerations that required thoracotomies and then ultimately withdrawing support. And then 1 just reiterating that there's no small procedure ended up with a ventricular injury from the chest tube placement. That patient ultimately did survive. So again, considerations for procedures on ECMO, you have to balance the anticoagulation and taking care of the circuit with coagulation and controlling bleeding on the patient side. And so how do you go about that? It really does take all hands on deck, and there's more hands than what's displayed here, but you really need to make sure that the ICU, the surgical team, anesthesia team, perfusion, nursing, respiratory, blood bank, pharmacy, the patient, the family, everyone's on the same page and sort of understands what you plan on doing moving forward. So a little bit more on the details of managing anticoagulation for procedures on ECMO. And as I said, a lot of this I extrapolate from the experience of repairing congenital diaphragmatic hernia on ECMO. It requires a subcostal incision. There's generally some dissection, and then repair of the diaphragm, either with a prosthetic or autologous tissue. This paper reviews the experience from Cincinnati. And actually, the goal of this paper was to try to compare bleeding differences between 2 different ways to repair a diaphragmatic hernia. But I like this because they do describe their protocol, and it does kind of give you a sense of what to expect as far as bleeding complications. For them, they use heparin as their anticoagulant. Their goals are platelets greater than 100. They shoot for a 10A of 0.3 to 0.7, fibrinogen greater than 150, and an INR less than 1.5. They comment that Amicar was commonly used, but they didn't go into too much detail of how they decided to use it. And then before incision, heparin was halved. And then this is where a little bit of nuance or art comes into play. They would titrate it based on sort of the bleeding and response during the procedure. But what you see highlighted, when you look at the 29 patients overall who had a CDH repair on ECMO, 3 of those ended up with a reoperation for bleeding. Obviously, the patients who did require a reoperation for bleeding had a higher postoperative transfusion requirement compared to those who didn't. When you look at the goals of the paper, trying to see if there's a difference between patch or muscle flap repair, there was no significant difference in returning to the OR for bleeding. But again, just sort of one experience on how to try to strategize to approaching a complex procedure while on ECMO. Just to touch base on Amicar, aminocaproic acid, it's a fibrinolysis inhibitor, typically given as a bolus and then continued as an infusion after that bolus. One of the earlier experiences with this came from Boston, where they would administer Amicar at the time of ECMO cannulation for patients that they deemed at high risk for bleeding. That included patients that they anticipated a major surgical procedure within 24 hours of cannulation, or premature, extremely acidotic, hypoxic. And when they reviewed their experience compared to a cohort from the ELSO database, while there was no difference in survival or intracranial hemorrhage with administering Amicar, there was a significant decrease in surgical site bleeding, and particularly for the cardiac patients with administration of Amicar. And notably, there was no increase in thrombotic complications. So a lot of protocols have utilized this in the perioperative period to try to help minimize bleeding complications. Another adjunct would be tranexamic acid, or TXA, another fibrinolysis inhibitor, also given as a bolus and run as a infusion afterwards. This is the experience from the Netherlands. I apologize that the graphs are mislabeled. The one on the left is both intra and postoperative or perioperative transfusion requirements. Group 1 being those who did not receive TXA. Group 2, those who did receive TXA. You can see the transfusion requirement was significantly less in the TXA group. And then this on the right is just the total product utilization for the ECMO run, again, significantly less in those who received TXA. And then I just put this up here as an alternative. That some centers use bivalirudin as their anticoagulation while on the circuit. David Kay's team kind of routinely repairs on CDHs on ECMO with bivalirudin. This paper is nice in that it really does detail their strategy for perioperative management of anticoagulation before the procedure. Again, I want to emphasize that there is some nuance and art to this. For the intraoperative management, they do titrate based on direct observation with the bleeding and the circuit. And so, a lot of that does come with experience. It's not like you can just cookie cutter this to where you are. But the results are impressive. Of the 38 patients who were repaired on ECMO, while 40% had a major bleeding complication, that was mostly defined as a drop in hemoglobin greater than 2 grams per deciliter over 24 hours. None had fatal bleeding, none had non-surgical site bleeding, and none had bleeding that required re-intervention. And then also of note, there are no circuit complications, so no thrombosis of the circuit, or they didn't have to change out any circuits. So again, I just put that up there as reference for an alternative. Back to our case. And the patient was stable, but obviously didn't need to plan for a laparotomy to address what was going on in the abdomen. So we got our team on the raft, discussed with the ICU, anesthesia, perfusion, our goals to prepare the patient for the operating room. We reduced our heparin rate. We lowered our 10A goals to about 0.3. In this case, we did bolus Amicar and have an infusion ready. And what's helpful here, we do have a typed up protocol for this. And that's just, I think, essential for these cases so that everyone involved can quickly reference the protocol and what sort of the expectations are through the course of the perioperative period. In the operating room, we did a transverse laparotomy. We noted 3 perforations in the terminal ileum and large volume contamination. We washed out the abdomen. We resected the dead bowel. And actually, the case went pretty smooth, all things considered. No concerns for bleeding. We did leave a drain in the abdomen, brought up an endoleostomy, closed fascia. And postoperatively, the patient also, not to simplify things too much, but she did fairly well. She did have a transfusion requirement and product requirement postoperative, but didn't have any major bleeds. We did continue our Amicar. We loosened our anticoagulation parameters about 2 days post-op. And we also didn't have any major circuit complications. She was ultimately decannulated on day 10 and progressed well through the rest of her hospital stay. Actually, I had her stoma taken down before going home. And I saw her in clinic a couple months ago and took out her G-tube. She's really, remarkably doing well at home, considering how sick she was at presentation. So just to recap and summarize and sort of tips for approaching, major procedures on ECMO. Obviously, the first thing to consider is, can you come off ECMO? Do you need, the best way to not deal with the circuit is to get rid of it. And how urgent is the procedure? Do you have some time to plan and strategize? Before you proceed, make sure you assess the circuit, the oxygenator, the cannulas, get a sense of your clot burden. Do you need to exchange? Be ready to exchange postoperatively or if the clot progresses. And then have a well thought out plan on how you're going to adjust your anticoagulation. Are you going to use adjuncts such as TXA or Amicar? Make sure you have blood products available. In the operating room, there's a host of topical agents you can use if necessary to assist with hemostasis. You can consider leaving the chest or abdomen open, plus minus leaving drains to assess for postoperative bleeding. Then obviously just close and meticulous postoperative monitoring. And with that, I'll finish. Thank you.
Thank you, Dr. Waltz. That was a great talk. We're going to take just a quick pause while we flip things around and move over to our panel discussion area. So give us maybe 3 to 5 minutes while we get set up for that. Okay, welcome back, everybody. Thank you for being patient with us. Our next sessions that we have lined up today deal with support for patients, families, and providers. So our first session is going to be led by Dr. Sarah Rubin. Dr. Rubin is the co-director of the Critical Illness Recovery for Children program, or the CIRCLE program, here at UPMC Children's Hospital of Pittsburgh. And she's joined with Taylor Huntington, who is one of our PICU fellows, and Sam Brynan, who is one of our ECMO specialists here at Children's Hospital. So I'm going to turn it over to them.
Hello? Okay. So I just wanted to start off, there is a quick content warning. We're all in healthcare, but portions of this presentation are directed about actually removing a child from ECMO support. So it is a little bit more in depth than just weaning of care. So indications for terminally weaning a patient versus decannulating. Any patient where discontinuation of care is decided, but they're not able to survive full decannulation, the amount of time that that can take. So some reasons for that can be a bridge to nowhere. So we all know ECMO is a bridge therapy, but if curative therapies for whatever reason are no longer an option, family decision at any time if they choose to redirect care, and the patient is again unable to be decannulated, and same with adverse events such as like intracranial hemorrhage, if the decision is made to withdraw and they cannot decannulate. So preparation and consideration. So even when the decision is made to terminally wean a patient, careful monitoring and assisting with patient care. This is all from kind of the ECMO specialist and the bedside perspective, still maintaining proper care, monitoring everything, holding cannulas, even though you know the plan is to wean, terminally wean, preventing any kind of adverse event or dislodgement of cannula before that happens is still important. Finding optimal patient positioning for family comfort. So if you need to switch up a crib to a bed so family can lay with them, if you need to help move the patient into family's arms, if that's their preference, those are all still things that we would be involved in. So supplies we bring in, and I'll kind of go into what these are all used for. At least 4 tubing clamps, any kind of towel or absorbent pad, trauma shears or anything that can cut through the tubing, 2 one-way tubing caps, and saline-filled syringes. And then beforehand, you're going to want to collaborate with everyone involved in this patient's care, bedside RN, the RT, the physicians, child life social work, music therapy, art therapy, make sure all of the legacy items are done, and if supportive care is already consulted, having their involvement in as well is super important. So our process for actually terminally weaning, we start off with adjusting our alarms. You're going to want to widen your flow alarms, turn off your pressure monitoring through the circuit entirely. You'll take your flow alarms to 0. However, you want to decrease your RPMs and not turn them off because some alarms we can't prevent. So if you have negative flow, so backflow from when you clamp, it will still alarm. So you don't want to turn your RPMs off entirely so you can prevent that from happening. You'll prep the area. So you'll kind of decide based off where the patient is being held, where the best place to cut the circuit is. You'll prep that area by putting absorbent pads under and then kind of around the tubing so that family doesn't have to see any kind of extra blood from that. So you'll squeeze the tubing to flatten, place clamps on both sides. This kind of prevents any blood from coming out of the circuit into the area if you flatten it first. You'll cut the tubing in the middle, but you do want to leave a little bit of space so that you can place the tubing caps in without having to unclamp. You'll fill with saline so that there's no air in that area, and then place the cap. You can remove the clamp from the patient side, cover and secure the remaining tubing so it's out of view from family. You'll turn your RPMs all the way off and shut off your circuit. We cover the components with a sheet, but we usually just move the circuit out of the way without unplugging, because unplugging it can be loud. It always makes a lot of alarms regardless. So we'll usually just keep it covered unless family prefers it fully out of the room. So our goals through all this, maintaining patient and family dignity, letting them have a say in how they want things done, providing as quiet and peaceful as an experience as possible for something so awful for them, and then supporting the family foremost, but then also afterwards each other, because there are a lot of people involved in the care of these patients that usually spend a lot of time with them. That's all I have. Thanks.
And then we're happy to answer any questions about this process or helping advising families and helping them know what to expect and supporting them throughout it.
So we're focusing on terminal weans here. And this process for sure is going to be traumatic. There's nothing we can do to take away all the trauma from families. But one of the ways that we can minimize the trauma as most as we can is preparedness. And so our focus really is from every aspect. I'm speaking from the PICU attending aspect and PICU fellows, et cetera, is to talk the family through what is going to happen and be there for them when things are happening. So even in our most perfectly planned procedures, things always go wrong. And if it's just something even simple as like, the pulse ox gets stuck or something comes unplugged and there's alarms. So just letting the families know ahead of time that alarms may go off and that's okay. And also having our ECMO specialists talk the families through, well, what does it look like when we come off? Where's all that blood gonna go? Is my child gonna suffer because of that? And that's a question that the family may ask to many different people in the room before, during, and even after. And then we need to be prepared for families to have these kind of questions. I think every family is going to be different. And I think one thing that we do very well is establish relationships with families before we get into these kind of situations. Our ECMO specialists are always at the bedside and so amazing, building that relationship and trust with families. Our supportive care team is absolutely incredible and essential, particularly in continuity terms, because the PICU team is always changing. And then also having the PICU team who the family has built a relationship with and trusts, all of that comes into this terrible situation being as well planned and thoughtful for the families so that the trauma that they have can be minimized and they feel supported from every part of the team and every person who's in the room or around them.
If anyone has questions at any point, please feel free to ask. Otherwise, I can just talk a little bit about planning for sedation during this process. Obviously, it will depend on your patient's neurologic status. Usually when advising families, I really tell them to focus to look on the patient's face and nowhere else. Explaining the breathing patterns will change. There will be a lot of change in the skin coloring and other aspects of their child, but making sure that their face looks peaceful. And so you can have the family focus on their child and try to tune out everything else that's going in the room. Obviously, you're working with your nursing staff really closely to have several PRN doses of whatever opioid and benzo you have planned for, and then usually I will still continue whatever drip opioid they were on, if not go up depending on where they're at. And then, as you know, making sure neuromuscular blockade has been off for some period of time before starting the process.
Do you feel like some families really do you feel like some families really want to be part and see what you're doing, and some just sort of want to stand back? And how do you sort of figure out how involved that you're going to allow them to be?
Usually I feel like their focus is on the holding, and we kind of do our stuff up from them. So if they're cannulated in the neck, if they're holding, we kind of go on a table behind them. We explain what we're going to do, and then if during the process they don't want to look over, they don't want to be a part of it, they don't have any more questions, we just kind of have already walked them through it. We do everything and move our things out of the way. So we kind of keep it as out of sight as possible, unless that's something that they seem like they want to be more involved in.
Do you do any planning for like the what ifs? If the, the alarms go off or anything like that?
We try to avoid them, but we do let them know as we start changing things, especially because if we come in when we're turning the RPMs down, we're touching the screen, we're doing a lot of stuff with that, and I feel like that's what draws a lot of attention. So as we do that, we say, we're doing this so that it's a little bit more quiet, but things might still beep, everything is fine, everything's still going as planned, but every once in a while the machines kind of are a little bit too sensitive to some things.
And Taylor, once the machine is off and sort of out of the way, and you're there with the family and the child, where do you go from there? Kind of how do you address that?
I've usually kind of talked or set expectations with the family before that we're happy to be in the room, but I usually step outside and give them time just with their child, and they'll know that I'm right there, and set the expectation that I'll come in 5 to 10 minutes and listen for heart sounds and declare death at that point. But if it's someone who seems like they feel uncomfortable or feel less familiar with the surroundings and stuff, then I'll stay in the room with them if that seems like their preference. Obviously, if the child seems that they have any distress, or we'll be in the room throughout the time, but oftentimes by that point, the family is okay just to focus on them and spend that time. One other thing I had a question about was if usually when planning these, we terminally extubate and then do this process. Have you had any other kind of a different order, choosing for families to choose to keep the breathing tube in?
I think that depends usually on patient status and how comfortable we think we can make them, how quickly we think things might happen. And also, again, family preference. Sometimes the tube is kind of the last thing they're thinking about. Sometimes they really want it out to see their whole face. So I think that's also another thing that can really go depending on everyone's preference and the patient themselves.
How do you deal with having other people in the room? So if they want, all their family to be there, how do you sort of have that conversation about, well, maybe we should have just the two of you there, or how do you kind of help them through? Because it's hard for them to know, with the family probably wanting to be there, but then maybe they want to be alone with their child. How do you sort of address that from a supportive care standpoint?
I usually try to find a time when it's just that whoever is the primary caregiver in the room, and make sure they don't have other family that they may feel pressure from, and give them the option and say, this is about you and your child, and this important time together. Whoever you want there to support you, we can make that happen, and whoever you don't want there, we can say there are rules, whatever you need to facilitate that room being exactly who you want in there and not who you don't. And usually families are pretty understanding. It doesn't take a lot of, and I feel like often parents want it to be just them and their child, but we can always modify as needed.
You have a couple of questions that have come in the chat. The first question is from Tall John, which we all know, who used to be a PICU fellow here at Children. So welcome, John. We're delighted that you're with us. The question that John has is, it says, one thing I struggle with here is the pharmacokinetics of cysts on ECMO. We know that the drug undergoes Hoffman rearrangement, but we don't know if that process varies on ECMO as it does with TTM. Do you have a standard period of time, say maybe an hour, where you feel comfortable that the cyst is off?
I usually try to have I think I agree with John. I usually try to say around an hour prior to doing anything. And ideally like to see that there are muscle twitches or the patient's moving to feel like aren't masking any discomfort.
Another question that we had come in, Sam, do you offer patient families to hold their child while still on ECMO, or do you only offer holding after clamping and disconnecting the circuit?
No, if they prefer to hold beforehand and place the child back in bed for actual disconnecting, we can do that. If they want to hold them through disconnecting, we can also absolutely make that happen. It's another one of those things that is whatever they're comfortable with, we can work around.
I think one thing that sometimes is unclear is exactly sort of how you're going to go about this process. And so I think just making sure that the whole team speaks about it ahead of time, because now, like Sam said, there are so many different options that are available, especially with the smaller ECMO circuit, how much things can be maneuvered to really make it as comfortable and calm for the family as possible.
There aren't any more questions in the chat. Very important content, I think, to go over. Last year, this session received a lot of really great feedback. That's why we had it back again this year, because we do think it's really important to kind of go through, these next couple of talks where we talk about, the futility of ECMO and how we deal with that for the families to make sure they do get the death with dignity, and then also how we can support the patients, the families, and the providers. So as we move into our next couple of talks, those are the things we're going to talk about. So we're again going to just take a quick pause from our feed so we can bring our next panel in and then go ahead and get moving with that. Thank you so much, Sarah, Taylor, and Sam, for answering the questions that we had. Okay, we're going to go ahead and get started with our next session here. Our next session is interdisciplinary family support, and we have members from our art therapy, child life, music therapy, and social work teams here at Children's Hospital of Pittsburgh. I'm going to go ahead and let Laura Nolan get started. She's going to introduce herself, and then we're going to have the rest of the panelists introduce themselves as well. Thank you, Laura.
Okay, hi, welcome everyone. Thank you for joining us. As Merritt said, my name is Laura Nolan. I'm our child life specialist in the CICU, and I'm joined by many members of our interdisciplinary psycho support team.
I am Brittany Meyer, and I'm one of the music therapists here at the hospital.
Hello, I'm Katie O'Connor, and I'm one of our art therapists here at the hospital.
Hi, I'm Maureen Hennigan, and I am our child life specialist on 7A.
And I'm Jonathan Rabon. I'm the social worker on the CICU unit and the 7A unit. So I'll start it off with the social work role during ECMO. So there's about 30 social workers in the hospital, and I have the 7A unit and the CICU. We are some of the first responders called for the family whenever an ECMO run is being made, and we are there to support the families in that moment. Some families don't really want any support in those moments. They want to be left alone. They want to be with family. Some of them want whatever we can can support them with during those situations. So we are a go-between between the doctors and the family. We're there to support the families in that initial stage. And every family has different needs. Every family has different situations. Some families, they have children here as well, siblings here of the patient. Some of them are living a long distance away, so they have housing needs. Some of them, their situations all vary. So, and they're going through this critical stage in their life. So we're there to try to game plan with the families and support them. So in the initial stage, like I said, I kind of go in between the medical team, kind of give them updates, try to see what's going on with the patient, and get them into a room where they're by themselves and support them in that way. Once everything's situated, then I'm trying to triage and game plan with them long-term planning. So some families have to figure out work-related needs to be here with their child. Some of them don't have housing, so I try to help them with Ronald McDonald House or Family House. We are lucky in cardiology where we have a lot of funding that was donated to us, so I can pay for housing for families, so I can get them into Family House and pay for a week stay for them or whatever is needed for that family. Some families don't have money for food, so I try to help them with meal vouchers. They might be going through some mental health concerns during this time as well. So getting them linked up with our transplant psychologists if they're involved, our regular psychologist, and our psychosocial team. Some families don't have insurance. We get some Amish families that come in too that they don't have the resources that other families have. So talking to them about what resources are available to them. We put on their medical consent needs as well. Some families are involved with children and youth. Some families are brought by a brother, an aunt, an uncle. So finding out who provides consent for those families, and then providing ongoing support throughout, setting up care conferences with these families, with the medical team, and just supporting them throughout their whole run in the CICU or wherever they're at.
Okay, and again, my name's Laura, so I'm one of our child life specialists in the cardiac units. Just an overview of child life for those who aren't familiar. So our backgrounds, our educational backgrounds are in applied developmental psychology, and we specialize in pediatrics and kind of explaining serious topics and medical topics in kid-friendly language. And we also serve a role to promote coping and adjustment in the hospital setting. So in an ECMO context, in kind of my setting in the cardiac ICU, typically our patients are sedated while on ECMO. So a lot of my role comes in as sibling support. So if I find out that a patient has been cannulated, typically I'll communicate with Jonathan and the medical team. And then I will ask if the patient has siblings. If they have siblings, I talk to the parents about kind of explaining ECMO in a kid-friendly way. I typically say that it's a machine that's giving brother or sister's heart and lungs a break so that they can rest. Another thing that I offer is I have a little prep book for siblings. So if they are to come back to the ICU and see their sibling on ECMO, I like to make sure they are prepared in what they're going to see before they come. So I have kind of an educational page with pictures of hearts and lungs on little cartoons, and then I have pictures of the actual ECMO machine so that they know what they're going to be looking at. Before they come back, I might cover the cannulas with blankets and make it look a little bit more kid-friendly in the room as well. For normalization, again, blankets are a great tool. I usually find out what the child likes. Recently, I've had Minecraft fans or Mickey fans, and I get maybe a Mickey Mouse blanket and give it to the parents to put on the child. Just that experience of normalization, of tucking your child in with a nice soft blanket instead of a hospital blanket could be really healing and helpful for the family. Reading books to the child. I like to provide books for parents to read to their child, and of course incorporating maybe their preferred music and things like that. I know some of my colleagues will talk more about legacy building and end-of-life support. We serve a pretty collaborative role in there as well with legacy building, locks of hair, handprints, footprints, 3D molds of hands, things like that. So some tangible keepsake items for the families to take home. Typically, when our patients are more awake and alert, if they're on ECMO or even VAD support, they'll sometimes go up to 7A, which is our step-down unit, and that is where my colleague Maureen works. So I'm going to turn it over to her.
All right. Hi, everyone. So I'm Maureen. Like Laura said, I work on 7A, so it's a step down from the CICU. So a lot of times I'll have the kids come up to me after they've been decannulated from ECMO. Some of them come up on VAD support. So I don't necessarily see kids that are currently on ECMO, but I'll catch them after. So my first assessment is kind of assessing where that child is. Do they need education surrounding their ECMO cannulation? Are they even aware that they were on ECMO? And then assessing education and opportunity to talk about their ECMO cannulation or decannulation. Sometimes I assess that it's not appropriate and that we'll just kind of talk about what's on their body currently. So if they have a VAD, we'll talk about that. And similar to Laura, just talking about how whether it's our ECMO or our VAD, we're helping our heart rest and things like that. So I have a lot of opportunity for education because the patient is now awake, but I just use my assessment skills to see where that patient's at and what they can handle in that moment. And then from there, if it's going to be an extended stay, I work a lot on developmental play opportunities, normalizing the hospital environment, and kind of making their hospital experience something they'll remember as a happy experience and not the VAD, not their ECMO, not the things that are really difficult to think about. So just some opportunities that I've given kids over the last couple of months. I've gotten a kid on a Berlin VAD outside. We go down to atrium events. We've seen Steelers football players together. So just trying to make the hospital environment a little bit more normal, but also providing that education as well. So that's my role up on 7A. I'm going to now turn it over to our art and music therapists, and they'll talk more about what they do with our kids.
Thank you. Again, I'm Katie. I'm from our creative arts department, and I'm one of the art therapists here at Children's Hospital. So what we do, or music therapy is also part of our program as well. Do the clicker. No, that's okay. So I was pointing up there. So as art and music therapists, it's always important to note that we are trained therapists as well, and Brittany can speak more to the musical training, but in art therapy school, you have to have your master's degree. So a lot of times art therapists will specialize in a certain type of art, but you don't actually have to be a good artist to be an art therapist. It's more about those therapeutic interventions. And so our work is evidence-based. There's a lot of research in both art and music therapy. And art therapy in the hospital while we are trained in mental health, and you might find us in a lot of private practice or behavioral health settings, here our role is obviously more medical based. And so we're here to help those patients process a new diagnosis or process what it means to be on ECMO if they're able, or their siblings. We do a lot of sibling support and co-treating with child life and music therapy. You can see a bunch of our goals up there on our slide. We can also work with fine motor skills to help enhance those, and gross motor skills, whether that might be standing and painting at an easel. But for the purpose of our kiddos that are on ECMO, we do a lot of work with the patients and the families, or the siblings and the families, because that can be a really scary process. And like Laura said, it can be scary to see. So helping process those feelings in a visual way. We have a beautiful creative arts studio here on our 6th floor that has actually 2 pottery wheels, a theater. And so whenever possible, we will bring siblings to that space. It doesn't feel like a hospital. It's a little bit more normal to what they might see at school if they have an art class. And so somewhat recently, Laura and I brought a few siblings from the CICU to the art therapy room to work on some legacy pieces. And so that's something that as art therapists, we work with our families, especially those that we worked with for a long time, on making some quality art pieces. And so that might be some handprint artwork, clay. We also have a wood engraver. So there are some projects that can take numerous sessions. The one thing we always like to remind all of our caregivers at bedside is to not promise certain projects or legacy items to a family. But if they are interested in art therapy, you can always consult us in Cerner or give us a phone call. Just because what we do with one family, we may not have the time working with that family to create the same project. So if you ever have a family that you think might benefit from some long-term art therapeutic care, please reach out.
Hi, I'm Brittany. Like I said earlier, I'm one of the music therapists here at the hospital. So similar to Katie, we are therapists. We just use music as the modality, I can't talk today, to work on different goal areas. There are 3 of us currently, and we cover the entire hospital. So we do see a lot of patients and work on various goals. But some of the goals I wanted to focus on today are more specific to our ECMO patients. And VAD patients, as well, as Maureen mentioned. So the first one, kind of looking at the increasing activity level. To be honest, when I first started here 5 years ago, I would have never thought about increasing activity level with an ECMO patient, but just recently I had the ability to work with an amazing patient on ECMO, I'm probably going to hear about this later, but she walked on ECMO. She did so many amazing things. And so my role in that was kind of, sometimes I would come in maybe at the end of a session with PT or OT where she had maybe some stressful and difficult moments from processing just being on ECMO, maybe the pain she was maybe experiencing during that time and the challenges she was having. And sometimes we would just listen to music. And then that would kind of open the door to just talk about what was going on. Other times I actually did have the ability to do a co-treat where she sat on the end of the bed and we really did some ukulele, and she learned to play the ukulele. And so then it gave her a coping skill to have while she was here at the hospital. But more commonly, we do work a lot with our VAD patients up on 7A. And so those patients can be here for a very extensive and long time. And so we'll focus in on increasing activity level, working on those developmental goals, reaching, grasping, supported sitting. And then of course, if the family's in there, we're gonna help them to learn how to be with their patient during this time and kind of how they can use music to incorporate some of that normalcy. Because if we think about music, music is so versatile and everybody uses it in so many aspects of their life. And so if we're thinking about a family, and I'm thinking right now just more on the younger side, like a mom at home is going to be singing to her baby. They're going to be doing wheels on the bus. They're going to be working on so many different goals just within that modality of music. And so how can I use that to then help this family to create some normalcy, but then also work on maybe some other goals that partner with OT and PT with increasing fine motor skills and gross motor skills. And then kind of working through the list. Increasing coping skills, like I said, is kind of depending on how we're using music, we're always in a way increasing coping skills, but sometimes that might be more of a specific goal. And so we can use that, like I said, with teaching maybe instruments, or we can provide just some relaxation and comfort within the environment. And so, to be honest, that would be the most common reason we get consulted for patients on ECMO, is usually for more comfort and relaxation. And so from what research has shown us and what we know is that even when somebody is sedated, we do know, they still know what's going on in the environment in a way, maybe not like they can't remember what's happening afterwards, but we can feel the stressors, we can feel what's happening. And so bringing in music, we use the tempo of the music we look at trying to just de-escalate the environment. And if you think about any room in the hospital, but a room with ECMO, there's so many sounds and noises going on, and they're usually in the CICU or they're in the PICU, and there's people running around, there's a lot going on. So having that ability to provide that music can kind of bring the normalization of the environment down. And we always use patient-preferred music and patient or family-preferred music, because that's going to create the most calming effect for that family. And we just kind of do it in a lullaby manner. So I've done anywhere from like screamo to rap and a lullaby. We can do it. You give us the challenge, we're up for it. And then kind of going down the list a little bit more. So in those cases where it does become end of life, we do offer bereavement support. And similar to Katie, we work with families. So we work with the siblings, with the whole family unit. And some of these families we maybe have worked with their entire stay here. Maybe they've been here for a long time. Maybe we're just coming in at the end and providing that support. But we can take the siblings, we can kind of bring them to the music space. Maybe it's just beating on a drum and making some music just to get out some of those intense feelings that we're feeling. Or maybe it's songwriting, writing a song for our sibling, talking about through what's happening, or with the parents. And then the main thing that we do for legacy building is providing heartbeat recordings. And so I know there's probably like a misunderstanding, and that's completely notable, that we don't have heartbeat recordings for patients on ECMO, but we always will do a heartbeat recording. We do tell the family that it might not be the same as prior to their heart prior to ECMO. And you might be a little bit more mechanical, but that still is a piece of their child that they are going to have forever. And so we want to always make sure that we can provide that. And just kind of as a note, we will provide heartbeat recordings. It doesn't matter if we know the family or not. You just call us. That is an automatic consult. We pretty much drop everything to go and do that. And then we will edit that and send that to the family. We work with our supportive care team, who I know you're going to hear from soon, on that aspect. So really, I think that kind of covers it for me. So I think that opens the floor to just questions, if anybody has questions that they'd like to ask.
So we didn't have any questions come in the chat, but we did have comments on how important it is to have you guys. And we really are lucky. So sorry, I just get a little emotional when we talk about this stuff, but you guys mean the world to us and to these patients and the families. So thank you. Okay, so now I'll get myself composed and we're going to move into our next heavy topic for the morning. I think lunch is going to be a welcome break for all of us from this today. So we're going to pause and then switch out our next panel. So our next panel is going to be led by Carol May, who is everybody in the hospital here at UPMC Children's Hospital knows Carol May. Carol is the person you call when things are really bad or things are really good or you need somebody to talk to, and she just provides like this wonderful listening, welcoming environment for anybody, whether it's patients, families, and providers. We use Carol a lot when we do have trauma that we're trying to unpack for ourselves as providers. So our next two sessions are going to be led by Carol along with Jonathan from social work. And then we're going to sit a couple of our ECMO specialists up there with her, Andrew Brantner, Sean Bodner and Sam Brynan, again, are going to sit over there with Carol while she talks about family support for patients on ECMO. And then they're going to kind of roll right into that, where do I put this box, unpacking the trauma segment that we have following that. So give us just a couple minutes to get those 4 people over there and set up, and then we'll be right back. Okay, we're ready to go ahead and get started with our family support session and our provider support session. I'm going to turn it over to Carol May, who is the manager of our supportive care program here at UPMC Children's Hospital of Pittsburgh. And again, she's joined by Jonathan, who was in our last panel from our social work team, and then 3 of our ECMO specialists, Sean Bodner, Samantha Brynan, and Andrew Brantner. So Carol, the stage is all yours.
Thank you. Hi, everyone in the room and joining us live on Zoom. We really like the opportunity to make sure that we're focusing on 2 very important parts of caring for patients who are on ECMO. That would be the family and caregivers, and just as importantly is the staff members who are in and out in many different roles caring for these patients. And so we're going to talk a little bit about that this afternoon. I'm going to start with the idea of family support and how that really runs the gamut, depending on the circumstances of the ECMO run, if we would. So, does the patient have a planned event after a cardiac surgery with an expectancy of 1 to 2 days? Is this a child who was a previously healthy child that now comes in with cardiac disease that we found out about, a few minutes ago and now is on ECMO, or someone who's had a trauma and requires the ECMO support? So I think any of those situations will put families into a bit of a spiral. I think my interpretation in caring for patients even pre-COVID versus post-COVID, is they've at least heard this term of ECMO before. And so they may have some familiarity with it, but then it also may have increased their level of anxiety, stress, distress around this idea. And so I think what we focus on, especially not just with our supportive care team, but with all the members of the team, you in our previous interview got to hear about the support systems. I know we have colleagues from our occupational therapy and physical therapy I can see in the room today. All of them are very important because we each offer a different level of support for families based on our experience as well as our discipline. I think it's important for us to recognize that communication is vital in family support. So explaining to them what they're seeing, why they're seeing what they're seeing, what the cannulas mean, what the machine means, those things help with offering family support. Knowledge is power, and they often don't even know what questions to ask. And so I'm sure, all of us, the more we are exposed to procedures and surgeries and medicines and therapy, we grow our knowledge and we feel more confident doing that for the families. I think for me is really the number one thing to offer is, start with communication. And we know that families can be overwhelmed with certain disciplines. If a physician, a surgeon, an ICU doctor walks in, they may be a little bit more intimidated than they may be if Laura from Child Life walks in, and that's just because of who they are and what they represent. And so making sure that all of us are communicating effectively would be probably my number one idea for family support, and to make sure that we're answering their questions to the best of our knowledge. I would also say for communication, I also encourage people to say, I don't know, but let me find somebody that knows. So I think we often feel as medical providers, in that term I use loosely, every one of us that's in a hospital setting, we feel like we should know the answer. We don't, and that's okay to say, I don't know, but let me go find somebody that does. And I'm sure Jonathan and people in the room are nodding their heads, but I think I'll start with communication as number one for my idea for family support.
I can piggyback on that too. So in the CICU and 7A, specifically with our ECMO patients, we've started doing care conferences on a regular basis. We have multiple families that we do care conferences bi-weekly or weekly. That's where we bring in Dr. Villegas, Dr. Morel, Dr. Castro, with the other providers, whether it's cardiology, pulmonology, whoever's involved in the care, with nursing leadership to kind of support, answer questions that the families have, support the families where they are. Some families take the time to just use the whole session to answer or ask questions themselves. Sometimes they just want medical updates from the team, and for us to kind of give them a picture of where we're going from that point forward. And supportive care is there as well. So we're always trying to improve our communication with these families. I think for myself, the patient is really not my patient. It's the parents and the caregivers. Those are my patients. So I do whatever I can to build that communication with the medical providers and the families to support this traumatic event that they're going through, support them throughout those times. But just building on the communication, we do try to strive to, I think we do that in the PICU and other units as well, but we do a lot of different care conferences and family meetings with our families. So just want to piggyback on that with what Carol was saying.
I guess I can add into that too, especially with communication for our ECMO team. When we first meet these patients, we get them on to ECMO, and then as the parents come back after we get, as the dust settles, I know that we always provide a patient care family education manual for our ECMO system. It is a lot to take in, and it can be it is very overwhelming for these patients' families to come in and see their loved one on ECMO. So we go in, we start our communication, we introduce ourselves, we give them our pamphlet, which goes through everything with the equipment, commonly asked questions, but we always do tell them, it's going to take some time. Please ask anything of us. We are here to help you and take care of you and your loved ones. So, I think Sam could probably touch on that too. So.
I think another thing that's important to remember is using, I don't want to say simplified terms, but not always using the terms that we're used to. Because if you go in and say, well, their art line isn't in the right place, that doesn't necessarily mean anything to them. And especially when we're the ones like touching the screen of this big machine that they don't know a whole lot about yet. Explaining what things do and instead of what you know them as, I think is really important to kind of bring comfort and help them learn a little bit better and help support them and make them feel empowered to kind of understand what's going on instead of just using the jargon we're all used to.
I think Jonathan mentioned something, and I'm going to just highlight it a little bit more. He said the term meet them where they are. And I think that's really important for our family support because I think in any situation, but definitely in medicine, we do a lot of assuming, and we all know what assuming means, right? And so it's important for us to really, for those of us that are able to spend the time to get a clear understanding of what the parents understand or caregivers or whomever are at the bedside, and then don't assume that they've understood more than they have. Again, the jargon's a great example, but also to just meet them where they are, understand what their understanding is. And the best way is to just say, tell me what the doctors have told you, and then stop talking and see what words come out. And then you have a really great way. And that may not seem like, well, how are you offering support to the families by that? But we are then, because we're meeting them where they are. We're getting the information that we need to know to be able to care for the families, so that then they can make the decisions that they may have to make. They can have the discussions with the care team and be able to ask the questions to the people that are at the bedside. So I think that's an important part of family support as well, is to recognize that sometimes we assume we know what people mean, and often they have no idea. So I think that's, again, important. I think the other is that you've seen a lot of different disciplines today, and recognizing that utilizing everyone's skill at the bedside is really, really important, because each one of us has something special to bring. And our team here in Pittsburgh, I will say, is really good about calling those of us that have different experiences. So I just take it for granted. But utilizing your resources within your institution is really important, to get parents to talk and express what they're thinking and feeling. I think it's also helpful for family support if we have any type of parent support group. We've recently started a support group for families with families of children with chronic illness, and that is a very wide umbrella of description or diagnosis, if you would. And so we're going to meet monthly to allow these parents to just step away from the bedside. We're only going to do it for an hour because some of our parents won't leave the bedside, and try to encourage them to come down and just talk with other parents who are going through similar situations, and just expressing that for them. So that's one other thing that we're doing to try to help our families. And I know, like the NICU, they also have patients on ECMO. The NICU also has support groups and other things. But those are, I think, helpful for families to talk to somebody else that gets it. Like, I don't get it, like they get it, right? They're not my child. I don't know what they're going through. So I think that's another example of how we offer family support.
Linking families with other families on the units too. I mean, we have a lot of families that in the ICU downstairs and in the CICU, it's so small that families all get to know each other, so they all know what's going on with each other. So getting to support those families and kind of linking them up if it's appropriate during those times, but finding different ways to provide support for the families. And we talk a lot about family support. It's also staff support too. This is very traumatic for our staff members too, to have 4 kids on the unit on ECMO, and straining the staff members and our nurses that go through a lot too. So just providing support all around to everybody. And I think Carol's team is very integral in that, and everybody knows who Carol May is, and it's a very big support to our hospital here at Children's Hospital.
Oh, yes, question.
I personally get a lot of communication concerns from family members. There's so many providers that are involved with the child down in the CICU. You have the CICU, cardiology, pulmonology, whoever it is, and that's where we definitely have a lot of family meetings with these providers. Bring the providers in to talk, come up with a plan for the family, and kind of lay it all on the table with the family there, and they can bring their concerns. But I've had families that have brought concerns up like that and wanted to talk out into like a setting like that where they're not just talking to the doctor and then they don't know exactly where it goes from there. So bring it to all the providers together, all their attention together. So I have seen that, and we try to build on communication. It's going to be a big word here, but that's something that we try to enhance here throughout the hospital because you have so many providers, especially whenever a child's on ECMO.
Yeah, I think, the question of, is there a common theme? I agree with Jonathan, it's communication. I really think, unfortunately, families don't always have good coping skills, right? So they didn't come to us with great coping skills. And then often we don't know what those coping skills were because, we're just meeting them for whatever in the worst time of their life. And so that brings certain layers into it. And we'll often hear, oh, well, I don't understand, or they don't understand what I think or feel, or they're not hearing me. And I often think that's just because the parents sometimes don't take the time to ask the questions. And so there can be a negative sense, which is kind of what I think your question is. Is there something we should be doing differently to make sure that we don't have that? And again, back to the communication, but also utilizing your other disciplines who do have the ability to sit there a little bit longer and ask those questions and dig a little bit deeper as to, why they may be feeling the way that they're feeling, right? And so I don't know that there's a common theme amongst parents. I think we see the gamut of, they would buy everybody in the building a Christmas gift to, I never want to come back in this building ever again, and everything in between.
I think a lot of it too is that attendings are different. Whoever's on is different each week, and there's different ideas. And I know that whenever certain doctors come on, some family members want to have more family meetings just to discuss their plan going forward because they haven't seen that provider in a while. But I think there's a lot of changes in plans, and that and that's been a theme in our family meetings is having communication from attending to attending going forward to better support these families as well, not just on ECMO, but any kind of child, whatever they're going through. So I think that's a lot of concerns too.
I think if able, it's important for family support to try very hard to encourage the parents to step away from the bedside. And I probably can't swear, so I won't swear, but you're darned if you do and you're darned if you don't. Cut it out. And so, right? So sometimes we have parents that never leave the bedside and we're like, they just need to leave and take a break and this isn't good for them. And then we have some families that we don't see. And that's hard. And so it's hard sometimes because we don't know what else is happening outside of the hospital and what their other responsibilities are, or what their lack of funding is, or they don't, have a car to come in. And then we have people that don't leave. And so trying to figure out the best way of supporting families to say, I really think you need to leave the bedside. And, sometimes I'll even say, because I can, Sometimes I can say, I'm just going to sit here for 15 minutes with your child and I'm not going to leave the room, and I want you to go down to, X and do Y, and giving them that security. So when any of us are at the bedside doing our visit, sometimes it's okay, we feel like the parents should be there talking to us, but sometimes it's okay to say, you don't actually have to. I can support you by allowing you the time to go, do whatever, because I'll be with your child, even, if we can't necessarily communicate with the child. Those things are important. If you as the ECMO provider are going to be in a room for a period of time, you could say, I'm going to do this. How about you go ahead and take a break? Because families often feel like they can't, and they don't know that they can ask us for the permission to do that.
And they feel guilty.
Yes, there's a lot of parental guilt. And that's a very good point to bring up. And so if we just offer that to them, it's like giving them a gift, right? You don't say, hey, would you like a gift? You say, here's my gift to you. And that's kind of the same idea.
I think another important part of that is establishing trust with the families, the people at the bedside. You spend a lot of time, if you do have clear communication and you're always talking them through what you're doing, if that's what they want, if you're communicating with them how they want to hear information and they feel comfortable with you and you build that rapport with them, they're going to be a lot more comfortable stepping away if they're going to do it at all. So I feel like it's really important to work on that relationship with them so you can hear about, if they did have a miscommunication with someone, you can help rectify things like that. If they do feel like they want to step away but they're too nervous, they might feel comfortable doing it when you're there.
Carol, a quick question we had come in is how can we help other clinicians who do not have experience in speaking with family members become more comfortable in doing so?
That's a great question. But you posed it to the person that talks too much, so I'm not sure that was the right person to answer it. Setting up the safe space to have communication. And I always say that communication is an art form. It needs to be practiced. I've done this a long time, so I've practiced a lot. But just like we're giving parents the permission to walk away, we need to give our colleagues who are starting out and learning all of these things the opportunity to do it, but alongside of someone who feels comfortable. We do a lot of teaching in palliative medicine on how to break bad news and how to deliver bad news, and what is that warning shot and how do you reframe what you're saying. We have lots of terms for that as well, but I think my first answer to that is to demonstrate good communication skills and allow those people that are training with you the opportunity to take a dive at it, and encouraging them, we're all going to make mistakes and it's not perfect the first time, and it's taken me years to be able to be somewhat proficient at it. And so I think that's, giving them that safe space and demonstrating. That's a good question. Am I missing anything there? Okay. All right. I think we can transition into provider support. Jonathan laughs, and people know me because I'm old. My name's also very easy, but we have these things here at Children's called Carol May Days. Rhymes, right? Real cute. So when I was a staff nurse at Children's before I left and came back and started palliative medicine here, I remembered what it was like to take care of a patient who died, did all that care, postmortem care, took the child to the morgue, all those things, family left. But then I was the first one to get the admission because I had the less amount of numbers, right? And so there was no time for me to grieve the loss that I had experienced. I worked on a unit that we had kids that we cared for years and years and years who died of chronic illness. And so I knew them, I knew their history, their stories. Anyways, it was really important for me when I came back to Children's to give a safe space for not just nurses, but all providers to talk about what this means for them to care for children. I think a lot of times early on when we started these Carol May Days, it was that we had to talk about patients who died. And yes, that's part of what we talk about, but it's also the emotional distress that causes on what we see in medicine now. And, our children are sick. The patients we care for are sick for many reasons. And they go through many ups and downs. And we have, we want to be able to give that safe space to be able to just talk about their thoughts and feelings. And I always start by saying this is a safe space. Nothing leaves this room unless you want me to take it out of the room and we need to change a policy or a procedure or what have you. But it has to be a safe space first and foremost. And providers don't have to talk through it. They too can learn from others and what they just hear. And it can sometimes turn into a venting session. And that's okay too. Sometimes we need a safe space to be able to do that, but we generally end in a way of just deciding how do we move forward. I know that some people on the panel have been part of those debriefings, and I find that to be one of the ways that we help support providers. I think we do other things as well. I don't know if you want to talk about those?
Well, I can say for the support that you give us and families, it is amazing. I know that I've had several tough cases that I've worked on, and we've been able to talk through it. And, granted, those cases are very hard, sometimes emotionally to deal with. Just having someone to bend their ear for, to just be able to talk to you about it. And even listening to my colleagues, just getting through everything and listening to everybody's experiences, whether they are good or bad or in between, it's an awesome service that you do provide to us, to the families, to the hospital. It is just amazing.
I think what's important that we want to do and to share with others is that giving people the ability to be heard is really important. And we do it for our families, and we have to do it for our staff as well. We need to be heard. It doesn't mean we're going to change things, and we need to celebrate the good, and we have to talk through the bad and learn from things. And debriefings offer that opportunity to be able to just talk through how we feel. I think we were always, well, at least, when I was trained, it was like your emotions, you're supposed to leave them at the door, and you don't make relationships with patients and families, and you have to understand what boundaries are. I get that. And, if you're a staff person that's in the corner crying and the parents are, comforting you, yes, maybe we've crossed the boundary, but it's okay to have a relationship with patients and families. You guys spend 12, 14, 16 hours a day with these families. Like, you're gonna have a relationship. And so acknowledging that is important. I think it's also important for us to talk about, yes, we're in medicine. Yes, we are to do all these things, but that doesn't mean it's not hard for us. And, we often don't have people outside of the hospital that really gets what we see and do. And we all have our support systems and the people that love us and care about us. But often I hear, I can't talk to my husband or wife about this because they don't get it and they don't want to hear it. And I don't want to tell them how bad it really is. And so having an opportunity for safe space for providers allows for that.
And Carol's, she's developed a very strong team from her PAs, her nurse practitioners, Scott, and then all the way down to Chris Ward, their social worker, who's amazing and a very good support for our families and also our staff as well. She's a partner for me that I go to every day, so it's very good.
I think the other thing, not to just talk about palliative medicine, but there's, a lot of us do it without even realizing we're doing it, supporting each other, right? And, when you either, have changed a shift and you're telling each other about your day or, what the machine looks like, or I'm worried about this, you're also in some degree supporting each other, right? And so there are these formal debriefings we do, but I think there's a lot of informal debriefing, if you would, that happens all day, every day, when we are blessed to work with colleagues that understand what we do and how hard it is. And you'll see people talking in the hallways. That to some degree, that's a mini debriefing, if you would, right? Like, this is what I went through today, and how did you handle this situation? Or, oh, I'm taking care of that patient and that family, and it's really difficult for me. How did you approach it? And again, some negativity is normal in society. We just have to come out with the positivity at the end of it. But I think that's important to know that that's how we support our staff.
I think just having, like you said, we have the formal debriefings, and those are incredibly helpful. But I also think that because we have things like that, and it's so well known throughout the hospital that that is a resource that we have, that it's kind of given us a culture of it's okay to talk about that it is hard sometimes, even though it's our job and we signed up to do this, that it is okay to say that it was really rough taking care of the specific patient. And it kind of gives you that empowerment to go home and allow yourself to cope however you need to, because you're at least accepting that there is an issue in the first place and that you are allowed to be affected by these things. So I think it kind of created a culture of being okay talking about those things.
Any questions? Yes.
How do you say you address like sort of trying to correct patients and we're not seeing that progress by the color we are trying to figure out
That's a great question. I'll go ahead and repeat it because I'm not sure everybody heard it, but the question is, if you, as in your discipline, or to help a patient progress physically, emotionally, mentally, I'll just lump us all in there together, and we're not seeing that progression, I think the question is, how do you handle that sense of almost failure, right? Because if that patient isn't progressing, that means I'm not doing something right. If they're not coming off ECMO, I'm not doing it right. If their pain isn't well controlled, I don't know what I'm doing either. And so I think it's important to focus on what you have done well for that patient. When you start to feel that way and you say, okay, we've made it thus far and we may be stuck, and maybe going to your colleagues and saying, these are the things that I've done thus far. Do you have any other ideas of things I could be doing differently? Or bringing in other disciplines, talking to the nurse, or talking even to the social worker, or to the parent, or, what motivates the child. I think that's also important. Sometimes we don't know what their motivators were because we didn't know them previous to an illness often, or a trauma. And so I think finding out what helps to motivate them, what they like, what they don't like, how they've addressed challenges in their life previous to this, if there has been, and I think also relying on our mental health providers and our support systems, because sometimes if it's not just the physical, it may seem like it's the physical progression is stuck, but it also may be that the emotional and the oomph of the patient isn't there either. And so utilizing our other disciplines amongst the hospital to help us with that. We got lots of great support. Sometimes we just don't know who to call.
Thank you, Carol. This session is always really helpful, I think, for providers, because a lot of times we don't want to talk about things, but it's nice to have such a great support system, and you and your team do such a wonderful job for us here at Children's. You do so much for the ECMO team. Whenever we call you, you're always ready to schedule something, and we are so appreciative of everything you do for us. So thank you so much. There weren't any questions that came in the chat, at least from the time I walked up here, there weren't any. So if somebody did put something, I'll get that when I get back. But we are actually like 5 minutes ahead, and we're scheduled for lunch at 1, but Dr. Castro is able to give his talk now. Since most of our audience is remote and virtual, we're going to go ahead and let him present remotely. So we're going to pause real quick and flip over to him. He's going to do his pulmonary blood flow on ECMO talk. So once we can get that queued up and going, he'll go ahead and give that presentation, and then we will break for lunch right after that. Jared, do I need to pause the audio up here? Do I have to mute the room audio?
You guys hear me?
We can hear you, Mario.
And you can see my slides, yeah?
Yeah, we see your slides.
Okay, we're good to go. First of all, I want to say thank you for the committee that every year do a great job providing this ECMO conference, to Dr. Villegas and Mary and David Palmer and all the perfusion team and the ECMO team, that without them, we will not have the outcomes that the Children's Hospital of Pittsburgh has. And I also want to thank you to all the people who joined from Mexico, a mis amigos de México, un saludo a mi tierra, Parral, Chihuahua. So the talk that they give it to me to give it is talk about pulmonary blood flow on ECMO. And this is a very interesting talk because through the years, there's been a lot of change. So my purpose of the talk is, first of all, I don't have any conflict of interest. I don't have money from any of the companies. No Abbott, no Medtronic give me any money. So I don't have any conflict of interest. My only conflict of interest is that I work at Children's Hospital of Pittsburgh, and those guys page me for ECMO, and we're running to the hospital. So first of all, we need to understand what is the systemic to pulmonary shunt physiology, ECMO, when we have a BT shunt, what is being written, and what we usually do at the Children's Hospital of Pittsburgh. To understand these is the scenarios that we can have. One is having a regular single ventricle patient with a BT shunt or biventricular needing a palliative procedure stage 1. The other one is like the Norwood with Sano, that is another kind of shunts. And the third one that is nowadays very common, having a PDA stents. So those are the things that we consider, and those are the scenarios that we can have. Now we need to understand the BT shunt is a creation of the systemic to pulmonary artery connection to give flow to the pulmonary arteries. And this has been created, this started with the tetralogies of Fallot, and now it's very common for the stage 1 for the single ventricle patients. It can be the Norwoods or it can be any other. Nowadays also, the way we do it a lot of times is through the PDA stent. So this slide is very important because it's to understand what are the overcirculation, what are the complications of the shunt, and basically it's a balance between the systemic circulation and the pulmonary circulation. And I think this is the success to understand a lot of the first stage single ventricle physiology. If you had a lot of blood flow, then you can have a low perfusion for the distal, or you can overflow the lungs. So all those things to have in consideration that led you to, kidney injuries, bowel ischemia, heart rhythm, hypoxemia, if you don't have good enough pulmonary blood flow. So those are the things that we deal all the time with these kids. In ECMO with shunt physiology. So because when they call us for these kids, when the kids are arresting, when they're having a shunt obstruction, sepsis, all that stuff. And to understand what is the survival of these kids on single ventricle shunts, the overall survival in this paper is basically 48%, and it's almost equal as any other, as the ELSO registry for the survival of the neonatal or pediatric VA ECMO. So what are the indications they're gonna call us for these kids that they are having a BT shunt and needs ECMO? Probably they're gonna need it for cardiac output, post-cardiotomy, cardiogenic shock after long bypass run, respiratory failure, sepsis, cardiac arrest, or the shunt went down, shunt thrombosis. To understand to clip or not to clip. And I think this paper is very important. It's not a lot of patients, but in this cohort, 9 of the 35 patients were single ventricle with the shunt physiology. In the first 4 patients, they completely occlude on purpose the shunt to avoid the runoff to the pulmonary vascular bed. And these patients, all of those patients died to have an autopsy and shows lung infarct. So at that point, they understand, and they, in the next 5 cases, they leave the chon open, and they manage, and then at least 4 of them, they survive to be discharged. And that's when the concept start changing. And the reality is that we need to keep open this BT chon, or at least, partially clip it, not never close, because of the complications that they can have on the lung. Now, knowing that if a single ventricle needs to go on ECMO, even no matter what, the mortality is still high. Now, we know that this kid is being saved by the ECMO. So, and it's pretty, in this scenario, we need to understand when we need to clip, when we need to know to clip. And it's also related, what is if we're not clearing the lactate, if we're not perfusion good, when decision needs to be made. But also is like the expertise of teams. And that's why in this concept is very important to flow the ECMO in a high flows from 150 to 250 to 200 cc kilo per minute. And you can tell me, well, it's like 150 is a lot, but most of the time you try. I mean, I'm not saying that all the time is 150, but sometimes if you're 140, the lungs are decompressed and the perfusion and the patient is cleaning the lactate, I think is good enough. But those decisions are made in day by day and evaluation. Now, this is a very nice paper from the group in Atlanta where they review their strategies for the ECMO flow and the surviving, and the reality in these they survived. They say 70% of these ECMO runs came out of ECMO, and their plan of these ECMOs were from high flows, and basically they never clipped the chon, and the purpose of this was basically to clear the lactate and have all the scenarios better to come out of the ECMO. And one of the considerations doesn't matter if it's a SAN or it's a BT chon, they try to flow high, and they never occlude any of the chons. Now, this is an old paper from 1997. And you've been already probably reviewing this paper, because the NOMO, or no oxygenator membrane, bad concept that they bring it, and it's only 12 patients they use it, and they only discharge 3 home, but they usually try to do a centrifugal pump with the open chon, keep ventilating. But this is related with the kids did not have any problem with the chon. It was only a heart problem after the hypoplastic left heart syndrome. And you can see their strategy was basically using a centrifugal pump, no membrane, because they were blaming the bleeding on the ECMO. They were, and also on the oxygenator and the tubing so long and the cooling of the patient. So those were the things. But we need to go back that this paper was from 1997, and they claim to use the NOMO concept. That is, every time you read the red book, they're going to mention that concept. But the reality, I don't think nowadays do this in the regular practice. So what is our strategy? So for us is basically we need to have adequate both circulatory beds, the pulmonary arteries, the systemic circulation. We need to have a negative fluid balance, is very important for us. We need to bring down the lactates, and we need to control the base deficit, and that's all of us you better like it, the $20 in your pocket, gotta have a good base deficit, means having give some bicar and get ready the patient. And that's what me in our practice is always try to flow high, try to start winning down the lactate. If the lactate is not going down, there's any consideration. I will tell you that our practice, we never clip the chons completely, but there's a few occasions that I might remember that we use clip once in a while to chon to reduce the runoff, to help to improve the clearings, the lactate. The other thing for us, if the Norwood arrestor or single ventral needs ECMO, we need to have clear vision of what is the problem. And if the patient needs to go to the cath lab, we will go to the cath lab. So there's no waiting or hesitating to not go into a cath lab unless we're completely sure what is the problem. Sometimes we come out of ECMO from the OR because it was a lump and run. We already review everything, and we will do a try to come out of ECMO in the next day or 2 days. And if there's not a successful weaning in the first like 24 hours or 48 hours, we will go to the cath lab. Usually the other consideration in the first post-op hours of surgery, sometimes even we run without heparin, and we start probably 6 hours, 8 hours later. Or if the bleeding continues, we will run without heparin, knowing the risk that having a BT shunt, you can have thrombosis of the shunt. So most of these cases, we will, delay the heparin. So what is the cannulation strategy? The right neck cannulation, you can see this is a picture of one of our patients that, previous Norwood that needs to go on ECMO. And the considerations, you see one venous cannula in the atrium and the one through the carotid to the first supraortic vessel. A few things in consideration. We don't try to put too deep in the arch. Second one, you can obstruct the BT shunt if there's a BT shunt. And then you can argue that if you pass the BT shunt and obstruct the BT shunt, maybe you're entitled CO2. There's not secretions. And also you do an echocardiogram to evaluate where the site. And you also, the first quality measurement will be the X-ray. Then you might need to pull back the cannula. I will tell you that I don't think we're pretty aggressive putting too deep the cannulas, but it's always having consideration. Now, the other thing is, it's been reported, if you go straight to the shunt and then you perfuse the lungs and there's no systemic output, you need to pull back that cannula and also have that scenario in mind in case there's a problem. The other one is the central cannulation after post-cardiotomy. The patient is after in the OR, we leave the chest open, we use the right angle cannulas, we use the aortic cannula or arterial in the aorta, or sometimes we use the side graft shunt to perfuse. And those are the other scenario how we will run the ECMO after these procedures. We always go to a cath lab. This is a patient who has a SANO, and you can see that the patient went to a cath lab on ECMO, and that should not be that the ECMO patient being on ECMO should not be a contraindication for going to the cath lab. So what is our final advice for the single ventricles or patients with the BT shunt? And when you're on ECMO, you need to prepare for success. What does that mean? That you don't need to have residual lesions, or at least you already went and take care, like a shunt obstruction, narrowing of the shunts. You can revise by surgery, revise by cath lab. Either way, you need to solve the problem and move it forward. You need to have a fluid balance control. You need to be ready for, with the inotrope support, not be afraid to use inotrope to come out of ECMO. Sometimes you push with a higher inotrope. I know the stakes can be a little bit higher, but those are sometimes if you don't push out the kids, they will never come out of ECMO. That's the other thing. And you need to do a few winning trials if you're not. And remember, sometimes it's the false hope of ECMO, then everything is good on ECMO until you're not on ECMO, until having a complication on ECMO. So every day we're on ECMO is also a chance for complications. So sometimes we need to push the kid to move forward and be ready to come out and not stay in this false hope. So for me, this is basically my whole talk. I would like to thank you to the committee for the invitation.
Thank you, Mario. We really appreciate you making time for us. We know you're extremely busy down in Tampa. So thank you for squeezing us in this afternoon. We're going to go ahead and break for lunch now, and then we'll be back with our program at 1:45.
Okay, so we're gonna get started again. Our next speaker is our medical director of pediatric critical care, our critical care transport team. He is an attending in the PICU as well. This is Dr. Idris Evans.
All right, hello. I'm going to talk to you today about ECMO transport. So essentially, this is a commercially available Google image, but the whole point is how you're going to take this patient who's critically ill. This is a neonate who is in a warmer, hooked up to a ventilator, ECMO circuit, tubing everywhere, IVs everywhere, medication pumps. How are you going to get this patient safely into the back of a vehicle and back over to a accepting hospital? So brief history of ECMO transport certainly parallels the rise of ECMO itself as a modality. So heart-lung machine invented in the 50s. And in the 70s, Dr. Bartlett, who was a surgeon out on the West Coast, who then went on to University of Michigan, described 28 transport cases, half of which were pediatric patients, including 2 primary ECMO transports where a team went to the patient, cannulated them, and then got them back to their accepting hospital. So the images here, so one of the patients was a 17-year-old girl with Goodpasture syndrome who had a pulmonary hemorrhage. Dr. Bartlett and his team went to the hospital where she was at, cannulated her, put her in the back of a bread truck where someone hand cranked the ECMO circuit until they got her to this airplane, and then flew her to the necessary place, and then put her in the back of another truck and hand cranked the circuit to the accepting hospital. In the 80s, Dr. Cornish started to publish the refinement in portable ECMO systems that were then making transports more feasible. And then certainly in the 2000s, sort of the first dedicated ECMO transport teams appeared in the 80s. First one was 1985 with Cornish down in Texas, and then Bartlett went to Michigan, started one there, and then Arkansas also developed one by 1990. But then in the 2000s, it really started to grow in the number of transports because the technology improved, and then there were certainly more ECMO centers, and the data came out that suggested that high volume centers had a better survival rate than those that were not high volume ECMO centers. So all of this has sort of contributed to where we're at now. So this is what Dr. Cornish made out of a, I'm drawing a blank because I don't have my notes up here, Rubbermaid. Rubbermaid cart was what they made in the 80s, could only transport neonates at this time, old-timey ECMO circuit, roller pump. So a lot of innovation at the time, and certainly a lot of progress has been made. So with that setting, so why would you transfer a patient if you have the ability to cannulate a patient? So obviously it takes a certain amount of skill, infrastructure, and resources to be able to successfully cannulate a patient. So I think what is the most common indications are either ECPR has been provided for a pediatric patient at a non-pediatric hospital, and the ICU is not credentialed or comfortable taking care of the patient after they've been cannulated. Or the patient requires procedures that the referring hospital cannot provide. So the most common things are either a cardiac device as a bridge to transplantation, or lung transplant. So more in-depth procedures than the referring hospital can provide a patient. So then pre-transport considerations. So the first thing is, should we? So certainly when someone is calling in to Pittsburgh to say that they want to transfer a patient on ECMO to us, we're more than happy to help. First, we have to make sure it's the appropriate thing for the patient. So certainly, is there a neurologic exam that is reassuring? Is there any head imaging that doesn't show any catastrophic event? And what else I didn't put up there, but certainly can we provide the additional procedures or investigations that this patient needs? So that certainly is going to be something that's discussed before we even start mobilizing a team. And then if so, when? So as in most transports, we want the patient to be stable, to be in the back of a moving vehicle, but certainly even more so when they're on ECMO. So are the cannulas in the right spot? Are the organs adequately supported? No significant bleeding, clotting concerns. We have a stable anticoagulation therapy. The circuit looks good. And then do we have appropriate access to administer other interventions? So, because the thing is, if you're on ECMO and it's going well, you're stable. And so there's no rush to go out in the middle of the night with poor planning to go get the patients. So logistics personnel, others will speak more about this, but here we have a critical care transport team that's made up of a nurse and a respiratory therapist. We send a critical care physician, which is one of our ICU fellows, certainly with phone backup from attendings or senior fellows, and then a perfusionist to obviously run the ECMO circuit. We here do not do primary ECMO transport, as in we are not going to another hospital with a surgeon and surgical techs and all the equipment needed to cannulate. That is not something that we currently do, but certainly that does increase the number of personnel you need. All right. So then how are we going to go get them with mode of transportation? So we're going to drive, we're going to take a helicopter, we're going to take an expensive plane. So you have to balance between the available working space and some of the unique challenges that each vehicle provides versus the speed of getting there. So ELSO's recommendations are that if you expect to be in the back of an ambulance for more than 4 hours, you should probably think about flying. And then there's certain mileage distances that are recommended there about what would be an appropriate vehicle. So so some of the challenges, though, for those of you who have been on a transport, helicopters are very loud, very crowded, can be very hard to see at night, communication became difficult, you're working through headsets, not being able to speak to each other directly. And then certainly some of the equipment needs to be compatible with helicopters or airplanes to make sure it doesn't interfere with any of the navigation systems. So there's a lot that goes into choosing the right vehicle. Then you got to think about time. So this is a very simplified version of the processes that are going to go in to get this patient. So first, we've accepted the patient. We've gotten our team together. We've picked a time. We have all our equipment. We've done our checklists. Then you got to get to the hospital with the team. While you're there, obviously you have to assess the patient, all the machines that the patient's hooked up to, check the labs, meds, just do a very thorough assessment of the patient. This is probably, easily at least 2.5 hours in this box. And then you then have to transfer the patient to the portable ECMO circuit or change the circuit to a portable ECMO circuit, get the patient on the stretcher, get them hooked up to all the travel equipment, the meds. Then you got to get a patient into the vehicle. Now, if you're just going by ambulance, fine, it's one transfer. But if you're flying, as I'll talk about later, you got to get into a vehicle, possibly to then get to the helicopter. So there's 2 patient transfers involved there. Then you got to travel to the accepting hospital. Again, if you're coming in by plane, you're going to be landing in the sort of community airport here in Pittsburgh and then getting on an ambulance to come to the hospital. Transfer patient once they're in the ICU from the transport equipment into the ICU equipment, and then the ICU, the hospital takes over. So looking at studies, I mean, sort of the average amount of time reported in studies is 8 hours to go get a patient and bring them back. And that's within like a reasonable distance, not some of these several thousand-mile transports that have been published. Movement positioning, all of you in the audience who have taken care of patient on ECMO and had at least just get them to a CT scanner in the same hospital. Moving patient equals risk of an adverse event. It requires a lot of coordination and communication among the team. You can mitigate the risk by using the least amount and the most compact equipment. Certainly if the patient's on EEG at the outside hospital, we're not going to be on EEG as we come over. Within a limited space, the team has to be able to access the patients, the machines, vents, and ECMO, the equipment, all the medications. So certainly positioning the patient in the vehicle requires a lot of thought. And then everything and everyone needs to be secure during transport. There's acceleration and deceleration at various speeds. So, You don't want anything to come dislodged at the wrong time. Equipment, very brief overview. You need the transport ventilator. You need everything that goes in with the ECMO circuit. You need power sources for everything. You need all the medications. This is probably, if you're on ECMO, this is probably sedation, paralysis, vasoactives, antibiotics, anti-epileptics, whatever you're using for anticoagulation. Blood products. At least want 4 units of PRBCs, 1 of FFP, and 1 of platelets. So you need to determine whether the referring hospital is going to be providing these blood products for the team, or we're going to be bringing a cooler with us. That's also limited by time and distance. All the equipment you need to appropriately monitor the patient, the point of care device to check blood gases, lactates, warming equipment. Obviously you're coming out of the ambient hospital room, certainly in colder weather. The patient and equipment can suffer if you're in extreme cold environments, trying to get a patient onto a plane or into the back of an ambulance. And then PPE, obviously during COVID, a lot of ECMO use, a lot more transfers, and then you had to have everyone appropriately dressed on top of everything else that they were bringing. And then the monitoring, you're somewhat limited in the back of a vehicle. So your pulse ox, and especially when you're on ECMO, your pulse ox and end tidal may be unreliable depending on the native cardiac function of the patient. You have a limited amount of lab work that you can check during the flight. Noise and positioning in the vehicle may make it hard to assess the patient. Good luck trying to auscultate a patient if you're in the back of a helicopter. And then dark environments can make it harder to differentiate cannulas. The return cannula versus the capture cannula can be hard to see the bright red versus the darker one if it's 1 a.m. in the back of a helicopter. So this is our ECMO circuit, our portable one, SLED. We use the centrifugal device. And so we've come a long way from the Rubbermaid container, and that was only useful for neonates. And so when the team arrives at the referring hospital, we have to convert them to our travel circuit. So the advantages of doing this, people are still using roller pumps. Centrifugal is preferred for hemolysis. Don't know how long this patient's been on the circuit at the referring hospital, may have been running for a while. So then we could also change it over to the heparin bonded circuits and tubing to help minimize the chance of clotting. The transport ECLS equipment is intentionally minimized in length to try to minimize any chance of the tubing being caught on something and inadvertently disconnected. Staff familiarity, you definitely want people to be comfortable with the equipment they're using and not trying to learn a new model in the back of an ambulance. Flight safety, I already alluded to that some equipment isn't appropriate for aircraft because it interferes with their navigation systems. And then the disadvantages, certainly pausing the ECLS circuit is always a concern that something adverse is going to happen. And with that, changing tubing, there's a risk of embolization. And then, exposure to additional blood products through the transport circuit being primed. If transplant is the ultimate goal for the patient, certainly you want to minimize how much blood they come in contact with. Some unique concerns about flying, I already mentioned too. Flying, you need to consider how the team is going to get from the aircraft to the referring hospital and back. Some places like us, we have a helipad on the top of the building, but in some places you have to go land somewhere else, take an ambulance to the hospital, get the patient, get back in the ambulance, get to the helicopter. So multiple steps of moving the patient. There should be equal sign. Higher flight level equals a shorter transport time, less turbulence, and less fuel consumption. However, as barometric pressure lowers, it allows gas to expand. And so typically if you're flying around 3,000 feet in a helicopter, this shouldn't be a big issue. Airplanes are pressurized, not completely to atmospheric. But if you're for some groups that fly at higher altitudes, if gas can expand, a small pneumo can turn into a big pneumo. If there's air sitting in the circuit somewhere that's microscopic, it can become macroscopic. And then there's decreased gas exchange capability of the membrane oxygenator as atmospheric pressure lowers. So you have to be even more diligent about your FiO2 levels and what your PaO2s are in the circuit. And as I mentioned, it's a much louder, darker environment, which is going to impact your ability to assess the patient and communicate. Potential complications, pretty much the same as if you're just staying still in ECMO, bleeding, clotting, inadequate flows, desaturations. If you're on VV, depending on the type of cannula, you can get into recirculation, differential hypoxia, north-south syndrome. If you're on peripheral VA, hemodynamic instability, and then the big ones, something going horribly wrong with the circuit or the cannulas. So same issues that you're gonna run into any patient that's sitting on ECMO, but certainly with all the moving, you have to be very diligent that you don't cause any issues with the circuit. So these are some literature. This is from a group, if I remember correctly, Sweden. They've done something like over 700 ECMO transports at this point when they last published, mixture of peds and adults. So this is complications that they documented in the span of about 6 years, about 450 transports. So you can see they had about 20% of their trips involved some sort of complication. 6% of them trips had more than one. And some of them are immediate threat to the patient, right? So they had twice, they had clotting in the ECMO circuit, air into the circuit. Higher risk, the patient is not doing as great once they get in the back of the transport vehicle, bleeding, loss of tidal volume. And then some of the variable ones, which just sort of shows that for all the planning that you put into this, there's still other people involved, like the crew that is going to get the ambulance to you at the helipad and take you to the helicopter. So I would not have wanted to be on the trip where the wrong ambulance showed up, or ambulance traffic accidents, or you just forgot your equipment. So those are speak to the value of checklists. And then on the right here is a publication out of Michigan from that earlier surgeon I told you about the complications that happened with 221 patients. Again, missing items, didn't show up with the right cannulas, didn't have the stretcher. Again, checklists, things that are hard to control for. You're just having electrical complications of your equipment. Obviously, this was probably during primary trip when they were trying to cannulate, the patient arrested, cardiac arrest inside an aircraft, that's a nightmare. And then arresting after getting on ECMO and the patient actually dying. So, I mean, there's a spectrum of complications here, and some of them you can really plan for, and some of them you need a little bit of luck. So we look at outcomes then, because the thought is ECMO transport safe? So this is a group did systemic review. Here are 11 studies with a mixture of pediatric and some adult patients looking at the mortality, the survival of patients till hospitalization after being transported. And so they compared these survival rates to that in the ELSO registry for the same indication, cardiac versus respiratory, and found that there was no significant difference in survival between those patients that had been transported on ECMO versus those that had been cannulated in-house as reported to the ECMO registry. It's about 70% survival in the respiratory indication population, lower, around 50% in the cardiac, but that is aligned with the ELSO's data. And then another group used some of the studies I just showed, but just filtered out the pediatric patients, plus some additional studies to look at survival from the ability to be discharged from the hospital of the pediatric patients who had experienced ECMO transport, and found a pooled estimate of about 68% survival, which again aligns with what has been published in ELSO about survival with ECMO. So sort of speaks to the fact that you can safely transport ECMO patients, or you can safely transport a patient on ECMO. And in the literature, 0.5% of patients have died during transport. So a minuscule number, though certainly there may be some bias because people aren't going to report if all their patients are dying. Which speaks to just a plug for early referral. So, we're talking about patients that are already on ECMO, but as they were starting to do more ECLS transports, there's this talk of these patients that need ECMO, dying before the team could get there to either put them on ECMO or transport them. So, the study in 11% of the neonates died either before on transport or shortly after getting to the accepting hospital by ground. 10% of these patients were deemed unstable for transport or died during the transport. And then Hewlett et al. Talked about these 3 in-transport deaths because the patient needed ECLS and it wasn't available. So, and then with the Caesar trial, talking about the adult patients randomized to ECMO or conventional management in the UK, 5 of the 90 patients that were randomized to get ECMO died before they could get to the ECMO center. So early referral definitely matters. So in summary, ECMO transport is feasible and safe in the setting of temporary limitations in personnel, space, and resources. Assuming patient stability on ECMO, take your time. You don't want to be the person that forgets the ECMO equipment when you show up. Planning is paramount. There's a lot of behind the scenes discussion and making sure we have the right people, right equipment. There's no substitute for experience. We do about 1 a year here, which for a pediatric center is relatively busy. For reference, Stat Medevac, which is the primary adult transport team in our region, they do about 50 a year. And then early referral, when possible, is definitely preferable. So that is all I got. Questions later?
There is one question in the chat. Any issues going from a roller pump to a transport centrifugal pump?
Not that I have been made aware of. I mean, I think the perfusionists would be better able to speak on that. But I think in terms of when we have done it years ago, because more and more places are using centrifugal, there hasn't been any challenges that I've been made aware of. But I think I don't actually do it. So I think someone, a perfusionist would be better to answer. All right, thank you.
Okay, thank you, Dr. Evans. Next, we have a little bit more on transport. And that'll be from one of our PICU fellows, Dr. Alan Joseph.
Hi, everyone. I'm Alan. I'm one of the PICU fellows. I want to take you through one of the transports that I was on for ECMO transport, just to give you a little more detail and color as to kind of how that goes. And so we're going to kind of go through the whole team and the roles that everyone has and how it plays together, using an example from actually during the conference last year. So like Dr. Evans mentioned, the team that's traveling is a nurse and respiratory therapist, an ECMO specialist or perfusionist, and then an ICU physician, typically a fellow here. And then, I consider there's a whole team that makes up this enterprise takes a lot of people, right? So you have the whole ICU team, charge nurses, the whole ECMO team back here at home, including the surgeon and the specialist tech who are helping out. Our communication center, our blood bank, pharmacy, all play roles in how this transport has to go. So our respiratory therapist and RN, our transport team is incredible, and they have a lot. It's really amazing when you go on a trip how much they do. They do everything from providing navigational support to our pilots and communicating with air traffic control. When we get to the bedside, they're assessing the patient. They're working on transferring all of the patient's medications. And again, if this patient's on ECMO, it's usually not 1 or 2, it's usually quite a few drips. Mixing up our own drips, connecting over to our transport pumps, transferring the patient's either a trach or endotracheal tube, the mechanical ventilator, to our ventilator, talking to the family about risk benefits and the risk benefits and consent for transport, moving the patient over, and then we have a set of protocols for basic sedation, et cetera, and then working with the physician to guide treatment. And then of course they have to document everything that we do as well, because we need records of this inter-hospital time. The ECMO specialist, we always tell the junior fellows, when you're moving a patient on ECMO, you are no longer in charge, the ECMO specialist in charge. And that's because they're the ones who are responsible for the security and integrity of the circuit. And so the ECMO specialist typically, they're gonna first meet the referring hospital specialists to talk about where the cannula is, any issues, what are your settings. They'll look with the physician to look where the cannulas, are we happy with them? Is there any adjustments that we need the referring hospital to make, whether it be securing the cannula for movement, moving it, adjusting it, whatever it might be. And then really they're the ones who lead the way we transfer patients. When the nurses and respiratory therapists are ready and say, hey, all our drips are over, or let's move, or why don't we move the patient onto our stretcher and then transfer our drips, whatever it might be, they're the ones in charge. The transport that we'll talk about today, that was a patient who the referring hospital used the same pump we do, and so we just had to drop the Thoratec pump head from their pump to ours. But that was easy, but certainly if there's a roller pump, that can become more challenging. One thing I didn't put on here, but I think is really important, is that they also maintain a backup pump. We always travel with, in the hospital we have 2 pumps, but they also actually literally carry a backpack that has a backup pump with them in case of any issues. So my role as the transport MD, if I go on this trip, is, again, understand the medical background that brought to the patient to where they are, why are they being referred, and what's the issue? Are they having issues with their ECMO circuit that we might need to troubleshoot en route, or that'll need to pass on to the team that's accepting the patient in the ICU? Obviously, it's our job as the physician to then talk to the family about sort of what are the immediate medical issues. We'll assist in moving the patient, obviously do some medical decision making. How are we going to maintain sedation? How are we going to titrate vasoactives as need be, et cetera. And then we'll do once we have a sense of how the patient's doing, their assessment, et cetera, before we really pack the patient up and move, we'll call back here and speak to the accepting attending and fellow and say, here's what's going on. Here's what's changed from the time you first heard about the patient. Here are the issues that have arisen, how we've dealt with them in our plans for, however long it might take to get back, so that those teams are both aware and ready for any issues that might arrive and can help us troubleshoot anything that might be going on. While all of this is happening, the receiving MDs are obviously, like I said, they're supporting us with any required recommendations. There's a lot of effort going into organizing resources at Children's, not just before we leave, but during the fact that, say this patient might need a cath intervention when they arrive. Well, they're mobilizing the cath lab. They're working on getting all those things taken care of that might be needed. These don't happen in 10 minutes. They take time. Our charge nurses are obviously working on finding a nurse in bed space for the patient. The ECMO specialists who did not go on the trip are preparing an ECMO circuit, an additional one, and backups, et cetera. And then, of course, whatever surgeons on call and have accepted needs to be aware of the transfer, any potential complications that might need to be addressed, and really should be kept in the loop of any big issues. I add these things, I think it's important to recognize that this is it takes a system to move a patient on ECMO. So our communication center ends up being the place how we contact the ICU, they contact us, all of those kinds of things. They arrange the actual helicopter, et cetera. Our helicopter crews have multiple sizes of helicopter, but only one of them is big enough to maintain an ECMO transport. So it's stuff as important as that. Our pharmacy will provide typically our transport team a set of emergency infusions. When we take the patient, we will get a list of the infusions that they're on. And ideally, some of those we'll have ready with us. Sometimes we do need to take the infusions that the patient is on from the referring hospital. And then our blood bank's really good about providing blood products to us if need be, right? As Dr. Evans mentioned, you need to have emergency products available, and many hospitals may provide those products to you in a cooler, but oftentimes our blood bank will provide us those blood products. So I think it's important to just recognize how much time this takes. Just to go through, this is just sort of the timeline of how a typical call came in. So the chart says at 1 o'clock we were called to sort of make us aware. Actually, this transport was already in the works beforehand. This is a patient who needed a referral for durable mechanical support and potentially heart transplant evaluation. So it had been on the radar of our heart failure team for, I want to say, a couple of days, but certainly that morning they had moved towards transport. But the Paige sort of activating the transport team came out at 1. And it took us almost 3 hours to mobilize everything we needed. We need to make sure we have a fellow available to go. We need to make sure that the transport team is available and ready. We needed to make sure that the stretcher with the pump on it, a backup circuit, was ready. The circuit and backup circuit, I should say. All of our drips, all of our blood. I think it takes so long to get everything together that I think that was one thing I did not appreciate until actually participating in this process. That call came in at lunchtime and we didn't leave until 4 o'clock before we were even on the road. This was the hospital we went to was not that far away, and we did fly by air. So we were there only within half an hour. But then again, we spend a lot of time at the bedside, almost another 3 hours at the bedside at the referring hospital. And we'll go into a little bit of what that was. And then, leave the referring hospital again. We're quite quick to get back. And then takes us about 30 to 60 minutes to hand off care of the ECMO patient to the receiving ICU team. So one of the big takeaway messages for me is that this takes time. There's no matter how fast you want it to happen, it will not happen quickly because there's a lot of moving parts. And in fact, I think this is the value of having a team that felt comfortable at this institution, felt really comfortable managing the ECMO, and the transplant evaluation was what took time. There are parts that we maybe could have made faster if the kid really needed something emergent that we only offered, but we couldn't have cut 3 hours out of this time, right? It took almost the better part of half a day to get this patient here, if you look at 1 o'clock to 9 o'clock. So just to give you a sense of what you don't have to read all this, I just think it's important to understand of kind of what our transport nurses and team is doing. So this is us arriving at the bedside at 4:50. And so the team does the following. We look at the chest x-ray. We verify the endotracheal tube and the cannulas. We look at the vital signs. We assess the patient, document all of the endotracheal tube placement, where the ECMO cannulas are, how does the patient look, what's the vascular access, what medications is this patient on? And you can see the list of, I think, 9, 10, 11 drips that this patient's on, and really get a sense of who this patient is and what's going on. So that's 4:50 that we document this at. It's now 5 o'clock. Okay, we're going to start. We're going to start our process. Remains under the care of the referring hospital's PICU team while our drips are being prepared for transport. Continuous monitoring both by our team and by the referring hospital's team. This takes an hour to get all of just the drips transferred over before we can even move the patient over onto our stretcher. This here, an hour to an hour and a half later, we are switching the pump head over to our perfusion pump. And then it takes us about 10 minutes at that point just to move the patient from the referring hospital's hospital bed to our stretcher. I think this is just gives you a little bit of an insight into how the complexity of moving these patients. Again, if you've moved a patient before, you know that it takes time, and moving them onto this narrow stretcher that fits in the back of the helicopter really is a really complicated undertaking. And so there's a lot of communication involved and a lot of who's handing what where, who's in charge of what. There's a lot of closed loop communication. So I want to close by showing you a picture from this trip. This is about half of the equipment we brought with us. I think it's important to note that, here's a cooler in the back of the helicopter. You can see this is our big helicopter that we use for ECMO transports. You can see this is, Dr. Evans showed you the ECMO pump configuration. This is all the other stuff that we need. So you have a ventilator here. You have our equipment in these 3 big bags. You have many of our transport drips. So these are essentially, for those of you who remember VHS tapes, they're about VHS tape sized portable pumps, but that's a 30 years old, too old reference. But there's just a lot of pumps. There's a lot of equipment that you need at our transport team. It took us, I would say, 20 minutes just to get all of our stuff before we even had the patient to leave. So I think it just gives you an appreciation for how complicated this endeavor is. But certainly with our team and the experience they have and our perfusionists have, it was really a safe transport. And so I was happy to see that. And yes, there's a very nice view from our helipad. With that, that's all I have. I don't know if there's any questions or I can move on to the panel. Thanks, everyone.
So we're going to switch over. We're going to do another panel discussion. So we're just going to take a couple minute break to switch over to our other setup. We're going to do a discussion on transport with Dr. Idris Evans and Dr. Alan Joseph, who you just heard from, and one of our perfusionists, Dan Ross, and a member of our transport team, Stefan Stefanko. Okay, we're going to go ahead and get started with our transport panel discussion.
We were just talking before we went live that it'd be helpful, Dan, for you to sort of just give us your experience. You've done this both on the adult and pediatric side. Can I hear your experience as an ECMO perfusionist?
Yeah, throughout my career, both in Pennsylvania and Texas, and adult and pediatrics, I've probably done about 50 transports in total. The majority of those coming from Presby. A wide variety of reasons, from getting someone off bypass in the operating room straight to ECMO, or going and actually cannulating somebody at a smaller hospital that doesn't have the capability, and bringing them back. So I've run into different issues the whole way. I guess the best thing is to be prepared and have as much supplies as you could think of, and then be calm and trust your coworker.
A question had come up about any specific issues about going from a roller pump to a centrifugal pump for the transport pump. Is there anything specific you have to keep in mind if you're transitioning from one version to the other?
I would say nothing really. I guess just bringing all the equipment you would need if you're transporting your equipment. Make sure you have backups for everything. Test it before you leave, and then just matching the flow and blood pressure that you're trying to achieve that they were already at. And then I guess you're going to need the perfusionist help on the other side to clamp and cut out their circuit, and good communication there is always a key too. So.
What do you think would be most helpful for, obviously Alan and I are the physicians on the trip, but what would be helpful for physicians to know about the process? I mean, obviously we can help make clinical decisions, but certainly we're not perfusionists. We're understand the nuts and bolts of the equipment and how to actually make it function.
I would say a big thing is you always need extra volume on ECMO, and I know a lot of physicians are hesitant to give it, but when you're up there in the air and you're losing flow, and the only thing you can do is give volume. So I guess bringing extra blood and being cognizant of that. And then equipment-wise, we're lucky enough here at Children's, we do have the best equipment and back up everything, so it's very nice. But I guess the smaller and the simpler the circuit is before you leave, and like the less connections and drugs going into your actual circuit makes it safer. It's like less likely to get snagged on something and pulled off and have a traumatic event happen. So.
Dr. Evans, is in your role as transport director, are there sort of issues that you've seen, things that you've seen have done well, things that you feel like persistent patterns that hurdles that people have to overcome and they do these ECMO transports? Because like you said, we don't do them that they're like an every week occurrence and frequent. So there, I think, opportunities for challenges arise.
Well, I think certainly if a hospital is calling for help, they, for the patient's sake as well, they want the patient out of their hospital as quickly as possible. But you have to make sure the patient is going to survive the trip. So a specific example would be a teenage patient who presented to a community hospital, had an arrest. The leading differential is pulmonary embolism, which ended up being the correct diagnosis. So the referring hospital, 8 p.m. at night, she's on ECPR in their emergency department, and the ICU is not comfortable / credentialed to care for the patient. Now it's 8 o'clock at night. If I remember correctly, it was in the winter, so traveling wasn't great. It was close enough to go by ground, which would be preferable from a space standpoint, lighting, communication, everything I talked about the challenges with flying. But the patient was also not stable. We're still having clinically significant bleeding, even after cannulation, was requiring large volume product replacement. Was hemodynamically unstable. The circuit the support had not been optimized between the circuit and other medications. And so that patient stayed overnight at the referring hospital. certainly stayed in contact with them throughout the evening, helped provide clinical management suggestions, and then got everything organized. And crack of dawn, fresh team, went out by ground to go get the patient. So I think that's an example of where the referring hospital rightly wanted her or the patient to be gone as soon as possible, but the reality was it wasn't going to be a safe transport until the following day, when we're able to get control of the bleeding and get more hemodynamic stability for the patient. So these are usually, rarely is it ever, we have to go right now to get the patient. These take a lot of coordination, and that's not even accounting for like insurance approval and all the things and the red tape behind the scenes. But these take a lot of time and coordination, so you don't want to rush.
There's a question in the chat about a cannulation team or services that we offer. Well, we don't have that. If you can talk a little bit more about capabilities you have with having a perfusionist with you, like circuit changes, oxygenator changes, any kind of troubleshooting or things you can do with transport.
For us, we have picked up patients where we'll go to a small hospital outside somewhere, and it's not exactly the best ECMO circuit setup. They're just kind of working with what they have. So in that case, we will bring our full setup. We'll go with their cannulas most of the time. I would say very often our surgeons here have to, when we bring them in, we optimize their flow, change up their cannulation a lot of the time, maybe switch them from the chest to neck or vice versa. But like other services wise, I guess we're always open for consult. If anybody has any questions about our experience, feel free to call any of us. That's about it.
Yeah, I would say that as the fellows taking the primary transport calls, there's kind of two flavors of ECMO referrals. One is the patient's already on ECMO, and one is we think this patient is not on ECMO, we don't have that capability, and we want them to come to your facility. And I think as a fellow, you're going to go on either one of those trips, but you'd rather go for the patient who's already on pump. It's obviously, I think, to go with a perfusionist to have a patient who's on pump is, I think, a lot more reassuring than that patient who's being referred for a VV ECMO or a VA ECMO evaluation. I think is just always a lot more high stress because we don't have a program that we bring our surgeons out. I think that situation doesn't come up that often where you think that our referring hospitals, I think, are pretty good about reaching out early when they think that's a possibility for the patient. But definitely if the referring has the ability to put the patient on even in a suboptimal configuration, sometimes that's the right way to go. And as the fellows, we're coordinating with our, the ECMO surgeon who's on call, talking to our attendings, the ECMO team. We all know all those numbers like by heart.
Certainly the amount of equipment and personnel it takes to go do a primary ECMO transport is double what we already take. So, I mean, some facilities have the infrastructure to do that. Yeah, to Alan's point, if you're working in a hospital that provides ECMO support for a certain encashment reason, certainly want to communicate with the referring hospitals that earlier is better in terms of referral, because certainly, as some of the studies said that I put up, that obviously if a patient needs ECMO, they're incredibly critically ill, and sometimes it can be too late by the time the team shows up to successfully get the patient to the accepting hospital and have a desirable outcome. So early referral is definitely best.
Thank you guys so much. That was a great session. Idris, Dan, Alan, we really appreciate your time here with us today. Our next talk is going to be given to us by Amber Palmer. Amber is one of the lead perfusionists for simulation at the University of Pittsburgh Presbyterian, but she also lends a hand over here at UPMC Children's with our perfusion team. She's the the only perfusionist on the adult side that is trained to come over and do pediatrics. So we're really fortunate to have her come over here and help us out when we need help in the CVOR. So, and Amber is going to talk to us about physical therapy on ECMO. Is it safe?
All right. Hi, everyone. I'm Amber. So like Merritt said, I'm going to be talking about physical therapy on ECMO. And the ultimate question is it safe? So I'll be talking about it in the standpoint of adults and pediatrics. So for either cohort, you're worried about early mobility being an important factor in critically ill patients. And there's information and research out there to show that there is an improvement in outcomes when you help these kids or help these adults get physical therapy before a transplant, and it helps decrease a hospital stay. So I included the heart, the lungs, and then the centromag, because typically these patients who are receiving this long-term care are patients waiting for a heart or a lung, and they're on, in my standpoint, on a centromag VAD. So those are the patients that we typically see. So the main objective is mobilizing ECMO patients and how it is becoming a new normal in not just adults, but also in pediatrics. So the big question is, why can we do this in adults, but we can't do it in pediatrics? So it's something that I would say is newer for the little people, but it's starting to become more common. But it takes a lot of teamwork. It doesn't just take me as a perfusionist or an ECMO specialist or a physical therapist. It takes everyone coming together and talking about it and making a plan. So that's why I included the picture of everyone below, because it's definitely a team effort. Ooh, wrong way. So we classify therapy in 3 categories, because most of the time a patient's not just getting out of bed and walking. They're starting in the hospital bed, and then they're moving to floor movements to get into a chair, and then they're moving to walking. So it's a process. It's not just, okay, you're going to get up today, let's go. You have to ease them into it. So those are the 3 categories that we're going to be focusing on today. I'll keep doing it. So what's our approach? Like I said before, we have to create focus groups, and those include your perfusionists, your ECMO specialists, your physical therapists, your occupational therapists, your nursing staff, and your doctors. Everyone has to come together and say what their concerns are, what their goals are, and how we're going to do this. Because what my goals are different than what the nurses' goals are going to be. And same for the doctors. The doctors might have a higher achievement or a higher goal than what we're at yet. So we have to kind of make sure everybody is on the same page. So we want to do this in a safe way. And that's always the most important factor, is making sure that everybody knows what their role is. Everyone's speaking up when an environment becomes unsafe, because your patient could be stable 1 second and then the next they are starting to crump. So you have to quickly figure out how you're going to resolve that issue. So you have to make sure you plan for those ahead. So goals as a perfusionist and an ECMO specialist, because this is my standpoint. 2 major questions that we always ask ourselves is, how is my cannula secured, and how will I monitor the flow? So how is my cannula secured? The most obvious way that you would think that you should make sure your cannulas are secured are with sutures. But when you see these patients that are on ECMO for a long period of time, their sutures start to fall out or rip out. So you want to make sure that they are put in place, new ones are tied in if the old ones are starting to look a little crummy, because you don't want that suture to come out and not be your fatal flaw of the whole movement in physical therapy. Another thing that we do more in adults than I would say in pediatrics is a Foley anchor, which is this top right-hand corner. We stick that on their shoulder blade near their clavicle, or we put it down in by their belly, and that helps secure the cannulas depending on where they are cannulated. So here at Children's, a lot of neck cannulation, and at Presby, we have a lot of FEM-IJ cannulation, so we want to make sure everything's secure. This patient in particular, he has his neck cannulas in, and he was a 3-year-old, and so he's a toddler, and it's kind of impossible to get toddlers to sit still and make them understand how sick they are. So that's another way that we had to figure out how to secure a cannula for this type of patient, for a toddler. So we came up with a cannula hat, and what we did was we sewed Velcro onto the opposing side of where the cannulation was, and we looped it around their head, and we secured the cannulas with that Velcro, and then below we had a elastic band around their stomach to keep everything mobilized, so when he would scooch down or wiggle around, his cannulas sort of stayed in place. So this was sort of a trial and error. We started off with one hat, didn't really work. We started with this one, and you have to be creative when you're trying to provide physical therapy for little kids. So he loved dinosaurs, so we decided to give him some dinosaur hats, and he tolerated the hat. He liked it. You can see that he's up in a tumble chair, and he's eating a hamburger and drinking a milkshake or whatever. But so he was able to receive physical therapy safely, effectively, in a creative way. And below is just another picture. You can use a headband to secure those cannulas as well. So the second question is, how will I monitor the flow? Because it's great that your cannulas are secure, but when you're moving these patients around and you have little kids and infants that have coffee straw sized cannulas in their neck, it's hard to say and maintain flow. So we always try to have a second perfusionist or second ECMO specialist around, so they're watching the machine while you're focusing on the patient. And if you can see that the flows are starting to drop, we say, okay, well, maybe we need to move their head a little bit to the left or right and readjust them to see if those movements are any better. So again, it's a trial and error of figuring out, but once you figure out what movements you can't do and which ones you can do, it makes it a little bit easier for the next time, and you can make improvements accordingly. So what does mobility look like? So in a hospital bed is the first part of that puzzle piece that I was talking about. And that can be a wide range of exercises where the patient's lifting their legs up in bed, or you're the physical therapist around moving their legs and getting them a little bit more mobile. Some patients can sit up on the edge of the bed and kick their feet. We had a patient that uses a little pedal exerciser and pedals while they watch TV or sit up in their chair. So there's different ways that you can provide physical therapy just by the patient staying in bed. The patient then, so there's a patient on the bottom. This is an example of them sitting on the edge of the bed. Physical therapy is to the side of them, and then a perfusionist is to the front, making sure all those lines are okay. So again, it's a team effort, but that's just one way we can provide therapy. When they're ready to move past the hospital bed, they might be going to a floor mat because they might be too little to walk or too little to do other things or not strong enough. So you move them to the floor or move them to a stroller where they can sit up and get physical therapy that way. So playing games with them, doing different puzzles, finding creative ways again to get them to move around. That's our main goal. And then I talked about the wagon. So again, there's another picture of the patient on the floor, playing on the whiteboard, drawing or moving magnets around. And then here is 2 more pictures of that patient I showed previously, up in a chair. And then here's his stroller that he's more, he's away from the bed, up in a different environment, and getting physical therapy that way. So you have to find ways to motivate these patients to keep them moving forward and to make them want to keep doing it. So you can say, hey, if you do this, like we'll bring a new toy in, or you can get this game, whatever. You have to find ways to motivate. And walking, recently we had a patient that you'll meet later who walked on ECMO here, and that was a really big deal for Children's Hospital because they hadn't had a patient that was stable enough and strong enough to walk. So that was a real learning curve in that aspect, and that's when teams again came to Presby and asked us how we do it because we walk a lot of patients on ECMO at Presby. So they asked for a second opinion, asked our tactics and techniques, and then they were able to successfully walk her. Again, when you're dealing with a teenager, they might not necessarily want to perform and do physical therapy. So what do you do for a teenager? Well, we brought in new hospital gowns that we thought were fun and motivational, and she liked to go down to Starbucks and get drinks. So we would, help her be motivated by saying, if you can get this, then we'll get you a drink. So it's helpful. Trips outside are another thing that we've done at Presby, where patients get to go outside. There's like a little porch at Presby that we like to take them to. So different ways to motivate. So as a perfusionist, I have to think of my challenges and I have to think of ways that I'm going to overcome those challenges. And perfusion, like I said, has to work alongside everybody else to keep that common goal going. But to keep control, we must ask ourselves, are the ECMO lines long enough? Are my cannulas secure? If I lose flow, how will the issue be resolved? And do I have enough battery for the trip? I feel that these are main ideas that are going through my head when I am about to move a patient. Are my ECMO lines long enough? While you can't do a ton once the patient's in line and you don't want to interrupt flow by making the lines longer, you can get creative on how you might move your circuit around. You might move it to the front of the bed instead of at the end of the bed, or you might move the circuit to the side to make those lines a little longer. Are my cannulas secured? Before I move any ECMO patient, I want to make sure that the sutures are in, but not only that, that I evaluate what the cannula site looked like prior to moving. Because if the cannula site was dry and there was no blood or oozing, and then when we put them back in bed, there is oozing and there is some blood, that might indicate that something happened while you were providing physical therapy. So you want to make sure you have a baseline of where you started so you know where you end. At Presby, we get x-rays every 12 hours. And if we have a reason to get another one, we will, but we look for cannula placements and ensure that everything looks good. We also measure our cannulas. It's harder to do that in pediatrics. But in adults, we measure our cannula from the site of insertion to the end of the cannula. And then I talked before, if we lose flow, how will the issue be resolved? And then do I have enough battery for the trip? I just make sure that someone plugged in the circuit and that there is enough battery. So when I go to unplug it, I look at my battery life to see, okay, I have 4 hours. So if something terrible goes wrong and we're stuck on an elevator, God forbid, or something like that, then I have enough battery to get me back. This is just a simulation of the perfusionists, nurses, physical therapists practicing walking an ECMO patient. So this was done prior to walking that patient that I had talked about before, because it was a big deal for Children's to walk. We wanted to make sure that some kinks were smoothed out before we proceeded with the patient. So here's just a simulation. And you can see that there is a nurse, a physical therapist next to her, a perfusionist or ECMO specialist is in front of them pushing the cart and holding the cannulas. And then you can sort of see in the picture, there's someone holding the pumps. And then when we actually did this the day of, when we walked her, there was a second perfusionist there manning the actual console, the pump cart, while somebody else held the cannulas. Okay, so for discussion, as we talked about, mobility for ECMO patients in the pediatric ECMO population offers unique challenges due to the vast range of patients that we see. So that's that 3 categories of physical therapy that we talked about. So that's why we have to find ways to safely and appropriately manage these patients while they're on to ensure that they're getting a safe experience. Next steps is to continue to work with the adult world to understand how they manage their patients when they're walking, because we're going to see this again. Maybe not soon, but down the line you'll see this, and we want to be as prepared as we can to walk a patient again when the time comes. I think always we want to secure our cannulas, make sure that everything on our end is good, so when we go to move them or go to provide that therapy, that no catastrophic events occur. And it's a collaboration, it's a work in progress. And I think that's what healthcare is in general, is a work in progress, because you're always looking to up your game, provide better care. So that's just a continuation of what we want to do. So that is all I have for everybody.
We have a question in the chat,
Okay.
Amber. So the question is, in your experience or institution, is there any cannulation configuration that makes PT more difficult than others? So I'm going to have you answer this, and then when Ryan and Caitlin go, we'll also have them, because they might have a different answer than we have from a perfusion perspective.
Yeah, so I feel like I keep repeating it, but at Presby, we cannulate femorally, we cannulate in the IJ, we cannulate centrally. Central cannulations were not moving. Those patients are, if they're open chest, they're not getting any kind of therapy. But if you're on VA ECMO, so typically our VA ECMOs are femorally cannulated, we put a Foley anchor on them. We make sure that everything's sutured and well secured. But as far as, I would say that's probably our most complicated ECMO strategy for walking them. But like I said, we just kind of make sure that the lines are long enough, that we have enough people around when we're doing more high-risk ones. In the pediatric population, I think that the Berlins are probably or VAD candidates are probably our easier ones to provide therapy to, just because of their cannulation, that since they're right on the heart, it's a little bit easier. But the neck ones, I think, are the hardest, just because they are patients that are typically the smallest, so they just have a little bit less reserve with their size cannulas. Okay, so that was the last question. And we're just gonna take a break for about 10, 15 minutes, and we'll be back. We're gonna set up for the simulation. Thanks. Am I good? Okay.
we're going to go ahead and get started with it's a kind of an interactive simulation and kind of talk on rehabilitation progression on ECMO. The whole idea behind this therapy segment in the conference was we found ourselves at our institution kind of having a disconnect between what was appropriate PT and OT for ECMO patients, what we could do safely, and we wanted to make improvements, but we didn't really know what to do. So that's, Amber kind of talked to how we all came together to figure out what exactly we could do. Typically you hear PT or OT and you think exercise, you think walking, you think running, you think treadmills, and that was kind of the disconnect that we had. We weren't thinking from baby steps on how you start from where you can't really do anything until you get to the point where you can progress, where you can actually go for a walk or be more active. So we're very fortunate that we have the PT and OT team that we have here to help us kind of change our mindset. And it really helped to change the culture of the PT and OT that we provide for our patients. And we're able to provide them with care that we hadn't done historically. So we're really fortunate that we've been able to make these changes and progress this way with our own ECMO program. So I'm going to turn things over to Caitlin Jenkins and Ryan Drabick. They are with our PT and OT team here at UPMC Children's Hospital of Pittsburgh. We have Megan Coyne, Jennifer Zyzanski, and Stacy Shipley, who are also participating in the simulation with us. They're all members of our ECMO team. Jen and Megan are ECMO core specialists here for us. Stacy is a NICU nurse, but she's also specially trained to be one of our ECMO RNs. So she's lending a hand to us here. And then we have my daughter, who's so graciously volunteered to allow us to strap her up to an ECMO circuit so that we could show how we can kind of do a progressive physical therapy session with a patient on ECMO. So Caitlin, I'm going to go ahead and switch over to you.
Thank you. My name is Caitlin Jenkins. I'm a physical therapist here at Children's. Thank you for having us here for this segment. I'm going to start our slides. So first and foremost, physical therapy, occupational therapy on ECMO is a multidisciplinary approach. We've heard this been reiterated all day today, but that is the only thing that makes mobility on ECMO successful. We need to have all of these people involved to even just initiate physical therapy. This is just some therapy considerations and the standard of care in our critically ill population, not only on ECMO, but this is kind of the guidelines that we work off of here at Children's to determine if and when our patients are ready for therapy. If you look from left to right, you'll see distinction of systems that we go through, respiratory, cardiac, neurological, to determine the stability of our patients and whether or not we can intervene. Oftentimes, unpopular opinion, but we can intervene on day one of ECMO. We can intervene when our patients are completely sedated and paralyzed. Obviously, our treatment interventions will differ based on some of the things that you see on the right-hand side, their medical stability, whether or not we can secure the cannulas if we are mobilizing a patient, whether or not our patients are awake, can they follow directions or not? Are our patients able to tolerate nursing care? Can they tolerate suction, or are they not tolerating any handling of any kind? And then we progress towards more of a tolerance to positional changes at that point. This is the same model that Amber had introduced to us. Thank you, Amber. And this kind of differentiates where we start with therapy. So we go from bed level therapy, working up to limited activity therapy, all the way towards out of bed therapy and ambulation. Depending on where you are at in your clinical course. So Ryan and I are going to kind of go through each segment, and thank you. Let's see if I can hold a million things. So the sim that we're going to do today, we're going to kind of go through each level of therapy and each classification of the level and what interventions we are able to provide.
Alrighty, so like Caitlin was saying, we're gonna go ahead and start with that progression of what rehabilitation looks like whenever we are on ECMO. First off is what we're calling bed level activity. And so that is what we're calling therapeutic activity and home exercise programs and what all that's gonna look like. So often this is when our friends are currently still sedated or not actively moving themselves. So we have to think about positioning, stretching, and splinting in some cases. So stretching and therapeutic exercise, passive range of motion is going to be provided by the therapist, and then it's also going to be taught to the families to provide outside of therapies. Sometimes when our patients are sedated and not moving themselves, we're trying to maintain range of motion in case if there is any increased tone based on poor positioning or long-term positioning. So for lower extremities, that would include Prafos, and then more specifically custom would be delta casting. And those are for patients who are we're trying to maintain that ankle range of motion. The delta splinting casting is whenever you're trying to get something more custom to that person rather than just that prefabricated Prafo boot that comes through most hospitals. And then we just had a recent case where sometimes you may also have to think about situations where increased tone happens, which may result from a stroke or prolonged ECMO use. And so working on tightness that now is affecting upper extremities, we may need an elbow extension splint, or we might need a resting hand splint, which OT can kind of pop in and start doing that fabricated thermoplast material or on whatever body part you may be needing at that point.
The sooner we are able to get into these patients' rooms and make these sort of splints, it prevents us from then reacting to different problems that we have down the line. If we're unable to maintain range of motion in the ankle, then it leads to many problems with standing and walking, which we try our very best to avoid.
While a patient is still in supine, if they are able to follow directions to do some exercise programs, we'll start initiating supine upper extremity strengthening and lower extremity strengthening. That's going to be some exercises through gravity-dependent positions as well as TheraBand and progressing that with resistance if they're able to tolerate it. We'll also start working on bridging for that patient as one of those supine exercises to really kind of help with assisting in brief changes or just bed mobility, starting towards that progression of things as well. We go on to the next slide. We do have a picture of some of our orthoses for lower extremities, starting off with a Prafo, then a delta cast, then we have a resting hand splint and an elbow extension splint. Another piece that we have up here is what we have is the ModaMed, which is a supine device that can work on a arm bike simulator or a pedal bike simulator that's meeting the patient's needs in supine before they're ready for any of that progressed edge of bed activity. Next, we are going to start talking about what we call limited activity. So that's also broken down into a couple categories that we clinically discuss. So bed mobility is the first one, where we can start working on long sitting or ring sitting if it's more age appropriate. For those infants and toddler kids, working on developmental transitional positions. So what it's going to look like getting from point A to point B based on therapeutic handling for those patients. This is also really important where we start to make sure we have our perfusionist and ECMO team around for us to, one, we're going to do it as a team effort. We're going to make sure that they're securing the cannulas, whether it's with a headband, whether it's with a hat, whether it's with what Zoe has on here today, which is this tight little cap thing that has Velcro for the cannulas. And we're going to do what we have started to initiate, which is like timing out, which is each profession is going to say who they are, what their role is, and how they're participating in this early mobility aspect of everything. That came really important to us whenever we started working on an older patient getting to edge of bed. So this is when we're going to start working on trunk stability and head control. Oftentimes, if we're cannulated in our neck, we're having a positioned away from where that cannula site is. So working on cervical rotation to midline or even past midline was really important to make sure that we weren't getting too stiff or we weren't losing any range of motion in our neck. Shoulder shrugs just built on up all that tension that patients can hold up in their shoulders and their back and upper back and neck muscles. Sitting edge of bed is working on cardiopulmonary endurance and strengthening, and it's like that first step towards, all right, we're getting our body to do more of this upright and more dynamic activities, which we're going to lead into. So once we are able to do that static sitting, which is just maintaining sitting itself, we can start initiating some of that upper extremity and lower extremity dynamic sitting. We can initiate that upper body and lower body thorax that we did in supine, but now doing in sitting. So we're working on trunk control and balance, but now we're also working on targeting, strengthening those muscle groups in a different position. We also like to start doing lateral leans or weight shifting while we're sitting edge of bed. So coming down onto our forearms or coming down onto our palm and pushing ourselves back up, working on our obliques while we're maintaining our erector spinae and our core muscles appropriately. Making sure, again, we have our perfusionist and ECMO team really there on those cannulas, because now we're starting to do some leaning towards and away from where that site really is.
Oftentimes, this stage of prehab, rehab can take days, weeks, or even months. So I think this is where we were seeing the disconnect that Merritt had mentioned. This is when we will start getting calls like, when can we walk? When can we get out of bed? And it's really pertinent to understand that these are the steps that we have to do before we can get someone out of bed.
Once we're able to get to that sitting edge of bed, you can really start to initiate some of those seated activities of daily living, where OT can really come in and start giving those patients some of that independence and some of that, I can still brush my teeth, I can still brush my hair, I can still do some of these preferred activities that are presented tabletop, because we are in a position of better kinematics to engage in some of those activities. Also, we can intervene with different types of machines. We have the rotorated pedals, and then we also have the upper body ergonometer or an arm bike. That's kind of taking that motomed that we had in supine and transitioning it into a seated activity that's also dynamic. And then we also have a picture of sitting edge of bed as well.
Commercially available Google images.
Yes. Then it kind of brings us to our big picture of what out of bed and ambulation is going to look like with a child on ECMO. So broke that down into a couple of activities and key points. So transfers. Transfers can happen in therapy to kind of establish what that looks like. And then we really tried to promote that outside of therapy, so that way it was happening more times throughout the day. It really depended on nursing availability and comfort level, but as long as we were trying to initiate the norm of this can be throughout the day and it should be throughout the day, is going to help the patient long term. So going from like a supine position to a supine position, we found it most easy to do a lateral sheet transfer. So getting a flat sheet from the bed, if one's not underneath them, rolling and getting that under them, and then finding those 4 points of contact and sliding from point A to point B. If that patient was able to and was doing well with edge of bed sitting, and you were practicing sit to stands, you can transfer with the stand pivot, or even a stand few steps of ambulation to orientation to that out of bed sitting. And then that out of bed sitting device is determined by the therapy staff, whether it's a standard wheelchair, a custom wheelchair. For those larger patients, for those younger kids, it would be into a tumble form, or a kid cart, which is a smaller version of a wheelchair, or even just like a standard chair if needed. The nice thing was working with therapy is you can have a lot more at disposal in terms of what lateral supports that patient may need for trunk support, what head control and head supports they may need in terms of securing a cannula to it. So a lot goes into planning and thinking about what all the patient needs for out of bed sitting. Another thing we like to use a lot is to initiate that upright standing or that weight-bearing tolerance through our lower extremities if they weren't able to do it just with handheld or external support from a therapist, is using a stander or a tilt table. We have that as an example for what we'll do with Zoe in a little bit here, just to show what an external support from a device looks like. how to transfer to it, and then how you can engage with that patient while they're supported in that standing. You're also going to start doing your pre-gait activities while you're in standing. You can carry over some of those activities of daily living that you were doing in sitting, now doing them in standing to make them a little bit more functional and a little bit more appropriate to how you would be doing them in real life, to kind of bridge that independence as much as you can. And then we kind of work towards that overall goal that we've kind of had in the back of our head this whole time, which is ambulation, and what that looks like as a team. So on the slide again, we just have some pictures from Google going over what things look like. We have sitting in a wheelchair with our cannula secured with a headband piece. We have a kid cart underneath that. We have a cardiac chair, which can be transitioned into supine and then into sitting. So it's great for that lateral sheet, and then turned it into an upright sitting. We have that tumble form chair, which is for those younger patients and toddlers. And then we have the stander, and showing how that provides some external support and the straps to keep them safe and secure.
So now we're going to do the sim. We're just going to go kind of through each level of therapy that we're going to do. We're going to give an example or two of some interventions. So in supine here, we have Zoe. And for the in-bed supine level therapy, Ryan's just going to place on some splinting mechanisms. And usually these splints, and we create a splint program to allow the nurses to don these and doff these without our presence. So typically consists of like 2 hours on, 2 hours off, and focuses on nursing carryover to continue that. From here, so at this point, Zoe would be sedated, and we're just working on positioning. This is also the point where we see a lot of our neonatal patients with focus on positioning and not so much mobility. So that's where we start in a patient of Zoe's age. Then after that, after Zoe starts waking up a little bit, some of the medications are being weaned off, we're able to start some active movement of both her upper extremities and her lower extremities. Oftentimes we find ourselves in situations with patients that are just now awake and interacting. However, they've been on a paralytic for the last 80 days. So you can imagine the amount of active movement is very little.
1, 2, 3. Go straight.
One other feature that we have available to us here at Children's in Pittsburgh, we have access to MedBridge, so we're able to customize home exercise programs, have them printed out with customized videos of how to do the exercises, again, when we are not present. So moving on, now Zoe is doing pretty good with her active exercises. She's able to do them by herself. She's starting to roll in bed. And our goal for today's session is to progress her to sitting on the edge of the bed.
So for that, we'll start doing with our timeout. This is Ryan from Occupational Therapy, helping Zoe get to edge of bed. We also have with us
and Caitlin from Physical Therapy. Oftentimes, this is also when you want to direct one point person to be the director of the session. So sometimes that is a battle, but really, in actuality, in an ideal world, either the therapist or the ECMO specialist should be the head of the session. You're gonna hold your cannulas. I'm gonna help you move, and Miss Stacy's gonna manage your lines, okay? On the count of 3, 1, 2, and 3. And what we're gonna do is move your legs over to the side, okay? Go ahead and start moving this one for us. Good, and then start moving this one for us, and then place your hand over here, and you can help with your arms pushing to move your butt to the side, okay? Everybody ready? On the count of 3, 1, 2, 3.
Sometimes in this situation, a patient may need help posteriorly at their trunk. So always have, sometimes OT and PT are starting off as a co-treat until a patient is able to have those split sessions. That's just in terms of the amount of therapeutic handling that patient needs, how many hands you have, and how that can both like facilitate as much functional participation in a therapy session as you can get.
So from here, we're just gonna do some pump exercises. I'm gonna lean you down onto your arm, and then we're gonna sit right back up, okay? On the count of 3, 1, 2, and 3, coming down to your arm all the way to the knee. And then go ahead and push yourself back up. Good, same thing on this side. Pushing yourself back up. Good. That's an example of something that would be considered prehab to getting out of bed or standing. If you're unable to sit and do dynamic sitting, you will also be unable to stand. We're gonna have Zoe lay back down. Our third section. So ready on the count of 3. 1, 2, and 3. And then the last section of the progression of rehab, this is one of the things we utilize. It's called a tilt table, often also called a stander. Just helps us get some lower extremity weight bearing in preparation for standing. At this stage, it's really important to have nursing set up all the lines, which we've already done here for the simulation. And then also having the ECMO specialists arrange the room to where they would like. So Ryan and I are just going to do a standard 2-person sheet transfer. This is one of the transfers we often recommend that nursing can do outside of therapy sessions. I'm just going to set this down.
Good edge. This is therapy.
Caitlin with PT. We're going to move Zoe to the edge of the bed first. On the count of 3. 1, 2, 3. And then again on the count of 3, we're going to go up and over. Yep. 1, 2, 3. So now that we've done the transfer, we're going to position her.
Once we have the patient over to the tilt table, there are straps that goes across our chest, across our legs, and across our hips, just to kind of keep our patient stable and secure in that tilt table as we're doing position changes. Tilt tables can be have lateral supports added, Hummel added or removed, support in different areas while we're also doing those position changing.
And then your ECMO specialist will be the ones to determine where they want to secure the cannula, how they want to secure the cannula. And we really rely on them throughout the whole session to determine how to position her. I am raising her up. 1, 2, 3. And this whole time, we are monitoring her vitals, how she's doing, how her face looks, overall, her response to being moved and therapy, throughout therapy the whole time. That's it. And then from here, we can do some other therapeutic interventions that are more functional.
While we're in a position, whether it's in sitting or whether you can start introducing some therapeutic activity, muscle strengthening. For kids, it's a play-based activities on things like squigs that are on like a surface that we have to pull off of. For example, you can kind of give them some kind of to replicate. So putting those resistive suction cup toys on the surface, having Zoe reach up. Job. Having her reach in different planes of reach. Good pull. Good job. Now to the side for another plane of reach. Good job. And try putting those together with both hands. Sometimes kids, when they have lines in their hands, are a little less happy. Putting two of the, make a, another one. Pull those apart for me. Zoe. You also can start working on standing ADL activities, whether it's a fine motor activity like a button or a zipper board or open containers. Anything that's something they would be doing age appropriately at home is really important. Button those back up for me, Zoe.
So this would be kind of like a multi-system activity. Zoe's having to use her musculoskeletal system. She's also having to utilize her cardiopulmonary system. She's also having to utilize her neuro system to accomplish all of these tasks. So while Ryan's finishing that up, I'm just going to go through some of the challenges that we face in therapy and doing therapy with patients that are on ECMO. I'll kind of go through each level of where the patients are at and some of the challenges that we face. At the in-bed stage, we usually come across patients' motivation and long-term goals. Some of these patients are here for a very long time. We are in their room every day, and it's not easy to participate. We also come across their medical acuity level, and oftentimes either the medical team or the nursing staff, well, we can't even get in the room. So that plays into how much we're able to do as well. And then our home exercise program carryover, having these patients do therapeutic activities outside of therapy. All of those challenges kind of carry through, in addition to the ones I'm going to list in the other sections. While we're at the edge of the bed with early mobility, some of our challenges are cannula procurement. Do we have the proper device to secure the cannula? Do we have the proper people to help us move this patient to the edge of the bed? Is the nurse available? Are 2 nurses available? Do we have an appropriate seating option? Many times patients can't sit in just a standard chair, so based on size and the level of support that they may need, we need to find an appropriate seating option. And then also room setup. Is the room big enough to have all of our supplies on one side of the bed? Are we having to rearrange the whole room before we do therapy? Similar goes with ambulation. When we're walking a patient on ECMO, there's a lot of people that need to be involved. It takes a lot of planning, and getting everybody in the same room at the same time is not always easy. And then, as I touched on before, patient deconditioning and readiness, it could take months from us doing therapy from day one to be ready for ambulation. And by that time, sometimes our patients are decannulated from ECMO by the time they're finally ready. And then same thing, room setup, but also the path of ambulation on the unit. We have to have somebody that's clearing the hallways and making sure that as we progress with ambulation, the hallways are clear for us to go through. This is our ambulation protocol. I think Merritt's going to do some of this as well in the next segment, maybe, but I can touch on it. This is just some of how we planned ambulating a patient on ECMO, making sure that your medical team is aware of your plans for ambulation, setting up the room appropriately, and having the appropriate people ready. As you saw in the simulation, we did the timeout to determine who is doing each role and what everyone's role is in the mobility aspect. Also discussed, the ECMO team member is tasked with the cannula securement and should be the head of the session. And then the therapy staff will determine the path of ambulation and determine who will also be responsible for clearing the path. Throughout ambulation, we'll have the patients consistently hemodynamically monitored. That's with all therapy sessions, but most importantly with ambulation, as well as the ECMO flows. And then the most important person, maybe, is the runner who follows behind us with the chair. You never know when patient's gonna ask to sit down and or just try to sit down. So you have to be prepared with that single extra person with the chair. This we already did, but this is just some of the people that we have with us with ambulation, and then the supplies that we have with us when we're ambulating a patient on ECMO as well. And this part is how we'll end with the ECMO parade. This is just kind of how our team is arranged when we did the ECMO simulation, as well as when we were ambulating an actual patient on ECMO. As far as I know, this was the first time we've done this in this institution, but it is becoming more popular, so preparation is the most important thing.
Thank you, Caitlin and Ryan. So that wraps up our simulation. We're just going to touch on a couple of things real quick. I'm going to have Megan and Jen show some of the things that we came up with in our perfusion and ECMO department as far as cannula securement when we were trying to figure out the best way to secure the cannulas when we decided we wanted to go ahead and move around. So we had a couple of challenges. We were presented with one patient that was teenaged and could listen, and we had another patient that was a toddler and couldn't listen. So it was challenging to come up with something to secure the cannulas, particularly for the toddler, because saying, don't touch that, stop turning your head, you can't yank at that, is a little difficult. So our teenage patient was delightful to work with in that respect. The toddler was a little difficult, but we came up with a couple different things. Caitlin and Ryan showed you the headband that we used. And then we weren't happy with the headband for the toddler. So we switched to this hat idea. Some of Amber's slides showed a ball cap, and we secured the cannulas to a ball cap with Velcro. And that worked for a little while, but it wasn't great. So then we came up with the idea of the beanie that you see Zoe wearing now on her head. And Devin can maybe get a good shot of that here in just a minute. And we decided we were going to secure that with Velcro on the sides so that it would help stabilize the cannulas. and we still weren't particularly happy with it. So the end result is we thought, well, if we loop it up over the head, maybe that'll help us. So it seemed to help a little bit. So we tried that, and that was better, but it still wasn't great. So then we had the idea of using an abdominal binder. So if Megan, if you can kind of show where the abdominal binder is, and we sort of looped the cannulas up over the head and then down on the front of the body and then secured them with the abdominal binder. And it helped to stabilize the lines and take some of the weight off of the neck so that we could go ahead and make sure that the cannulas were a bit more secure and they weren't tugging on the neck and causing bleeding or causing any other issues. So that's what we came up with for our department, and it seemed like it worked. It worked really well, particularly for a toddler. So if anybody who is watching has any ideas, or you're seeing things that you're like, oh, well, they could have done this much simpler, we're open to any suggestions that anybody might have that would benefit our patients down the road. So please go ahead and type those into the chat. But that seems to be what kind of worked for us, is we were able to just secure with that binder, and we were able to make for the safest transition for our toddler-sized patient, getting into the tumble form, getting into the stroller, and actually being able to mobilize that patient. Does anybody have any questions? There are no questions that have come into the chat. Caitlin, Ryan, anybody, Stacy, Megan, Jen, do you have anything you'd like to add? Okay, we're gonna go ahead and switch over for our next presentation. Just give us maybe 3 minutes to reorganize some stuff, and then we'll be right back with everybody. Okay, we're back for our last feature of the day. So today we're going to end with a huge win for our ECMO team. Sam Brynan is going to present our survivor story this afternoon. So I'm going to go ahead and turn it over to Sam.
All right, so I have a good story for us today. All the pictures included in this were approved by this patient and her family, so let's just get into it. So our guest for today presented at her local ER after feeling sick at home for multiple days. She was diagnosed with influenza A and was transported via air to Children's Hospital of Pittsburgh. She decompensated rapidly upon arrival and required emergent cannulation onto VA ECMO. So this is what we looked like on day 1. So some of our survivors' ECMO statistics, she was on multiple configurations of ECMO. So there were 20 days on VA ECMO, 6 days on VAV, and then we were able to transition fully to VV for 109 days. So we're at 135 total days on ECMO, which was 3,239 hours. So we did a lot of rehabbing with this patient. So this is day number 57. So hospital day and ECMO day are both the same since she was cannulated on day 1. So day 57 was first time out of bed into cardiac chair. Day 64, we were at edge of bed. This was probably not our first time at edge of bed, but 64 was the first day that we were able to do that. And on day 115, we walked. You cannot see the patient on this because there are a lot of people involved with walking an ECMO patient like you guys just saw, but I promise somewhere she's in there. So while she had a lot of amazing medical, it was a great story, an absolutely phenomenal case, lots of different ECMO configurations, a lot of different procedures. She was also a patient that was awake and hanging out with us a lot, so there's a lot more to her than just her medical story. She loved visits from her dog. She had a whole bunch of stuffed animals in her room. She has visitors badges that she didn't need because she was still here, but it said VIP on it. So she was a big personality and was really good at making friendship bracelets. You can't see it, but I have one here. So she's a lot more than just her numbers, but some more days for you. She was 162 days total in the ICU, 57 days in rehab, which was 219 days in the hospital total, and we were not the only ones who kept track of that. So just a reminder of where this patient started before they talked to you guys a little bit, and where we ended up. I'm going to pass this over to Kelly Gavel, one of our child life specialists in the PICU, and she's going to help us through a couple questions with our friend.
Hi, everybody. My name's Kelly. I'm the child life specialist here at Children's Hospital in the PICU and I'm sitting here with my good friend, Anna. Hi, Anna. So we have a couple questions. Everyone that's tuning in, this sometimes isn't the story of teenagers like yourself who can come back and tell us all about your experience. Do you want to introduce yourself and who you're here with first before we start?
My name is Anna Schaefer, and I have my family with me. I like to ride my horse, hang out with my brother and my friends. And I went to a Morgan Wallen concert.
And getting to that concert was a really big goal of yours, correct? All through rehab and your hospitalization too? Yeah. Why don't you hold the microphone and I'll ask you these, that way everyone can hear you the best. Did you have any prior understanding of what? Okay, now we both get microphones, so I'll repeat the question. So while Anna was down with us in the PICU, we realized that you were a really big Grey's Anatomy fan. So prior to coming to the hospital, did you have any understanding from your Grey's watching what ECMO was? Have you ever seen it before?
I did not see it, but whenever I rewatched like some Grey's episodes, I saw someone put someone on it. And I was like, I've been on that. That's cool. So
That's super cool. Do you think it was pretty accurate?
no.
So looking back, what did you think about the ECMO machine? Was it big and scary? Like, take us back to those first few days. You know, you woke up in the PICU, that first picture that Sam showed us in room 525, and I think it was February, correct?
Yeah, February 1st.
February 1st. And you didn't realize that it was February, correct?
Yeah, I asked what time it was, and the nurse told me whatever time it was on February 1st. And I was like, no, it's not. And my mom was like, yeah, it is. I was like, I don't believe you.
So how was that for you? That was a few months of your life. Was that scary? Was it confusing? What was the most helpful to kind of reorient you back to space and time?
It felt like a dream. It was like really weird.
I bet, for sure. And you'd miss Christmas.
Yeah, but I got it when we got home, so.
How did you celebrate all the holidays when you finally got home?
We only celebrated Christmas, but we had a bunch of family over.
And you celebrated for real? Was the tree still up?
Yes.
Excellent. So you woke up on ECMO. It was February 1st. What was the most challenging thing the first few days of waking up? You know, you were there, you were awake, you were talking to us. But what was the most challenging thing, do you think?
It felt like a dream. Like I would look at like a pack of Whitebees and they just looked fake. I was like, I'm in a dream, like this isn't real.
What was the most helpful thing? So when people started talking to you about all of the stuff that was connected to you, what do you remember? Where did people start?
They gave me this bear.
I think that would be Sam and I.
Yeah. And they showed me that this is the ECMO, and then I had a trach and chest tubes. So it like, I don't remember that, but like during the time, like I understood it. So
Yeah. So trying to visualize and show you what was on your body without, you know, you weren't able to sit up and like, oh, look, there's something in my neck, there's something in my side. So do you think those teaching tools were helpful?
Yeah.
Okay. So we'll do it again for another kid. That sounds like a good plan. So other kids do wake up on ECMO, similar to yourself. What would you tell them if they were sitting in front of you or you went to their room? What would be some advice that you would give to them?
about ECMO,
Yeah, just in general.
you'd probably get off of it.
You'll probably get off of it. What about therapies and stuff like that? Like getting up and moving and doing that stuff?
I hated it, but do it. Like, you need to do it.
You need to do it anyway,
Yeah,
even if it's
it's
really, really
important.
hard. It's important. I feel like your PT and OT pals are really happy that you said that. What would your advice be, Erin, for other caregivers going through this?
I would say trust your team of doctors, lots of prayers. I don't really know, just being her mom was my main priority, and just trusting in the prayers and praying over the hands of the doctors and the nurses and just trusting them in her care. That was really important to me.
So you did all your therapies on ECMO, you did all the good stuff, and then it was time to get decanned off of ECMO. What do you remember from those conversations? Was there something that was really scary? Were you excited to get off of it?
They did tests on me, and they were like, well, sometimes they would tell me, but sometimes my mom told them not to, so I wouldn't know. And then my mom was like, you've been off of it for a day. I was like, okay. And then she's like, we're gonna take you off of it. I was like, okay. But my mom told me that they had trouble with it, and so she was scared that I was gonna come back on it, but I didn't, so.
Erin, how was that for you, doing the test to see if she could get off of it?
It was wonderful. When they did the testing for her to come off, and I realized that she was able to be off of ECMO, I knew that it was in sight. The end of that was in sight. And when she came back, the day they took her down and then they brought her back to me, bringing her back down that hallway in her bed with no circuit, I cried, just cried. And then I hugged her surgeon and just thanked her because she saved her.
It was a lot being here for 200 plus days, for sure. And I can only imagine you seeing your kid coming back and after 100 plus days and oh my gosh, your body's doing it all by itself. I can only imagine how good that felt. I know how the staff felt, but I can only imagine how good it felt for you. Let's see. So now you have been obviously off of ECMO, out of rehab, out of the hospital for quite some time. When you got out of our rehab unit, you got back home, you saw your friends, you're just getting settled. How has it been? What were those first few days like, getting home, sleeping in your own bed for the first time in 219 days? What were those first few days at home like?
We had problems with my pulse ox, so it was annoying, but other than that, my bed was so much more comfortable, and I felt like I was free.
You felt like you were free? So besides the concert, what else has been your most favorite thing that you've done after you were freed from this hospital?
I got a kitten.
You got a kitten? That's so exciting. What's the kitten's name?
Dusty.
Dusty. Is the dog getting along with the kitten?
They're at different houses.
Oh, different houses. Gotcha. Very fun. What have any of your friends or any of your classmates, have they asked you about the hospital at all?
Not really.
Not really. Do you ever think that they're like wondering about it or wondering about your trach or anything, or maybe some of the scarring?
No, a lot of people like know my story, but like no one asks questions. But like I went to get my hair done, and I told the lady, I was like, "Do you have any questions?" Because I have a trach, and if I were to see someone with a trach, and I didn't have one, I'd ask them questions. She said no, but
She said no. Yeah. What would you tell some of the younger kids who are going home? I know your family has been really open about your story. What would you tell those littler kids who might be, just a little bit more self-conscious about their body or going home with a trach or some scars? What would you tell them?
to not worry about it. It's like it's not a big deal.
It's not a big deal. Gotta own it. Like you have, for sure. You feel like you fought for those scars?
Yeah.
Oh yeah, big time. I'm wondering if your brother or dad have anything else they want to add throughout this time, or if there's any questions in the chat too.
So it's my time to talk now?
Keep it brief.
Well, it was just a long journey that we all went through, and I'm thankful for the doctors and everybody in here who has made a difference in our lives, and I'm thankful my sister came home alive, and we're just so grateful for everything that we have now.
Do we have any questions from this crew in here or in the chat? I don't know who's moderating it.
There aren't any questions that have popped up in the chat. Does anybody from our team have anything? Oh, wait, we have Jonathan, who, I don't think you know Jonathan, Anna. He was a PICU attending here a while ago, he still holds a lovely little place in our hearts. But he's been tuned in for most of the conference. He says, your story is so incredible. What was it like to get back to school?
I have not been back to school yet. I do online, but I just got told that I'm able to go back to VOTech on Monday. So I'm excited.
And what will you be studying?
Cosmetology.
Excellent.
He says, congratulations.
That's huge. That's awesome. Anything else that you want to share with the team who's here today or tuning in online? Focus on rehab or the PICU or anybody else here? Mom can say it.
Just that there's always hope. Don't give up. A lot of people here, probably in the beginning, didn't think she might make it, but not one of them ever made me feel like that. So just don't give up, because I feel like that there's always hope, and she's living proof of that. So
We have people in the chat sending you big hugs, Anna.
I think those are all of our questions. If there's nothing else from the team up here, thank you, Anna. Thank you, Schaefer family, for coming back and chatting with us. I'm sure there's a million people who are so happy to see your face.
I know we're all very happy to have you here. I'm very thankful that you and your family came down to visit us once again. It was so nice to see all of you guys and get to give you hugs. And Ryan and Rusty, I know you didn't want them, but I forced them on you anyway, because I'm a hugger. But we are really thankful that you guys came down, and you certainly don't need to thank us. Thank you for letting us take care of you. And that concludes our program for today, or I'll get real emotional. So we'll be back tomorrow morning at 10:30. So tune in again to that. We have some other exciting content, and thank you to everybody for joining in.